Hussein, and the list is Dr. Salah Abeid. I would be discussing today a complete, simple review course on the spine and what is expected from the resident to know by the time he wants to sit for his boards. Nowadays, the boards, as an examination, are changed from year to year. A lot of the exam is concerned with observing the candidate, of how he examines the patient and what questions he asks to the patient. The examiner doesn't open his mouth. He's an only observer, and the score will depend on how well that candidate examines and asks questions the candidate, the patient used during the exam. We will start, first of all, with the anatomy and biomechanics and the skeletal and neural anatomy. The axial skeleton, as you know, as residents, consists of 33 vertebrae, including 7 vertebrae in the neck or cervical spine, 12 thoracic, 5 in the lumbar region, and 5 fused in the sacrum. Mind you, occasionally there are portions which are not fused in the sacrum, and we can call this lombardization of a sacral component. And the coccyx consists of 4 vertebral bodies, and these are fused at all times. This shows you the skeleton, the axial skeleton, and each of these vertebrae. We have certain curvatures that we are concerned with. One, which is a lordotic curve in the cervical spine. We have a thoracic kyphosis, followed by a lumbar lordosis and a sacral kyphosis. Now, these curves have a purpose. One is to maintain the balance of the individual. One curve balances the other. And with time, we see that we lose this balance. And this would give us many problems with the aging process, which we will be discussing. Intervertebral discs separate
شباب المحاضرة وقفت عند الدكتور جون. ما الآن
خالد، من أي سلايد بلشنا كان رايح؟
Okay, doctor, you can start now.
You're seeing now, right?
Yes, sir.
ما بعرف شو صاير، ما بعرف شو صاير. ما بعرف شو صاير. شو صار ما بعرف. سوري بس في problem عندي. والله ليه هيك يعني؟ شيء مش طبيعي. في شيء مش طبيعي. شيء سكرين. Am I clear now?
Yes.
Okay. قال لك لأي سلايد وصلنا؟ رح بلش من هالسلايد.
Okay, doctor.
Okay, speaking about the second lumbar vertebra. It is a heavy and bulky vertebra. The whole purpose is to bear the load of the body. It consists of a body, two pedicles which rise from the posterior surface and bound the canal, and these pedicles are joined by two lamina which form the spinous process. The pars interarticularis lies in between the two facets, the superior and inferior facet of the vertebra, which unite with the vertebra above and below. Motion in the facet joints depends on the position of the joint itself within the facet. In some, you have lateral motion, in others, you have considerable rotation, and in others, you have flexion, extension, and in others, you have a combination of motion. The arch and body enclose and protect the spinal cord and coda equina and form the vertebral foramen through which the nerve roots pass. The spinous process projecting posteriorly and the two transverse processes that extend laterally from the pedicle lamino junction provide outrigger insertion sites for the multiple muscles and ligaments that move and stabilize the trunk. The facet joints provide motion between two vertebrae. The superior You hear me?
Yes,
Am I
doctor.
online?
Yes.
Okay. هل أكون الإنترنت الكتنة? Please let me know when I go offline. Okay, I apologize. I don't know what's going on. So if you look at the circle which I have on this slide, it shows the facet joints. It shows the shape of the facet joint. It is the joint which is formed between the vertebral body above and below. Okay, so enough for that. So the vertebral canal extends from the foramen magnum to the sacrum and encloses the spinal cord and its nerve roots. The dura mater is separated from the bones by an epidural space that contains fat and extensive plexus of epidural veins. The dural sac continues inferiorly to approximately the middle of the S2 vertebra. Keep this in mind. And growth of the spinal cord lags behind the longitudinal growth of the axial skeleton. So you should keep these in mind. Okay? So this shows you the cord and its surrounding dura and the epidural fat and the epidural veins which surround it. We know that it consists of various types of neural fibers, which we will be discussing. The conus medullaris, which is the tapered inferior end of the spinal cord, extends to the L5 vertebra at the 3rd month of gestation. It is opposite to the inferior aspect of L2 at birth and reaches its adult location at the upper border of L2 at 5 years of age. So the conus medullaris lags behind the growth of the skeleton, and it takes 5 years to move from the end of L5 vertebra to L2 at the 5th year of age. Inferior to the conus, the dural sac contains the cauda equina, which is the lumbosacral nerve roots, and these are known as the filum terminal. This is a cord of tissue that travels inferiorly from the conus to merge with the periosteum on the dorsum of the cortex. Of the coccyx, sorry. Now, this shows you what I was speaking about. It tells you about the terminal end of the cord. It tells you about the filum terminal, which is a group of nerve fibers which end at the coccyx, the lower end of the coccyx. The dorsal and ventral nerve roots and the dorsal root ganglion converge to form the postganglionic spinal nerve at approximately the level of the respective intervertebral foramen. Because there are 8 pairs of cervical nerves and 7 cervical vertebrae, cervical nerves are numbered according to the vertebra above, not the vertebra below, which occurs in the lumbar region. For example, the C3 nerve root travels through the foramen above the C3 vertebra, and the eighth cervical nerve emerges through the foramen between C7 and T1. This shows you the various components of the cord. You see the spinal nerve is being formed by the dorsal root and the ventral root. The dorsal root has its ganglion present, and they join, and they have the gray and the white ramus to supply the peripheral end of the body and gain sensation from the end and allow it to come to the spinal cord. So these are simple physiologic terms that you should know. The thoracic and lumbar regions, spinal nerves are numbered relative to the vertebra below which they emerge. Thus, the L3 nerve emerges through the foramen below L3, okay, below the L3 vertebra. The first and second cervical vertebrae are different from the lower 5 cervical vertebrae. I would like to repeat this because I was not very clear. If you look at the cervical spine, the nerve will be in relation to the vertebra above, not the one below. While in the thoracic and the lumbar region, it is in relation to the vertebra below. Yani, for instance, if you have L3 vertebra and you have L4 vertebra, what passes in between is the L4 nerve. Keep this in mind. So these show you the various vertebrae of the upper cervical spine. We have the atlas, which does not have a body. It is surrounded by an anterior, posterior, and lateral arches. The lateral masses have the facets, and in the transverse zone, or we have the transverse foramen through which the artery, the vertebral artery, passes from C1 to the brain and becomes the basal artery. The odontoid has stolen the vertebral body of the atlas. It is like a pivot. It fits in between the transverse ligament, which is present posterior, and the anterior arch of the atlas. And we know that 50% of rotation of the head occurs at that level. So you have to keep this in mind. In the slide, you can see at this level, you see the transverse ligament, you see the odontoid process present over here, and this is held by the ligaments in between the arch of the atlas and both ends of the atlas in between. And this measures around 6.9 millimeters. And during fractures that occur, for instance, the Jefferson fracture, where you have an expansile fracture, if the distance is more than 6.9 millimeters, it will tell us that the transverse ligament is torn. The atlas C1 vertebra, it lacks also a spinous process, and it is essentially an oval ring of bone. The lateral portions of C1 ring are thickened into the lateral mass that consists of the facet joints. You have a superior and inferior facet joint, which is part of the lateral mass. The upper facet joins with the joint that is formed at the lower end of the occiput from both sides. The facet joints between the occiput and the atlas are flat. The atlas acts as a rondelle between the occiput and the axis. This shows you the facet joint, which articulates with the lower facets of the occipital condyles on both sides. They are facing inward, so it grabs both facets at this level. And we know that a good portion of flexion of the skull occurs at this facet. The lower facet grabs the facet of the axis on both sides, being that it is acting as a rondelle, and it holds both ends, the axis and the occiput, together. Of course, these are surrounded by ligaments and capsule. In the transverse extension, we have a foramen, which is called the transverse foramen, which the vertebral artery passes through. Now, the axis, which is known as C2 vertebra, has the tooth-like protuberance, the dens, that projects upward from the vertebral body to provide the structural support of the atlas. طلعوا على الصورة تحت. You see the odontoid leaning on the anterior arch. There is synovial tissue at the lower end, making it a synovial joint. And from behind, you have the transverse ligament, which attaches to both lateral masses of the atlas, and this measures 6.9 centimeters in length. The dens provides a pivot point on which the head and the atlas can rotate relatively freely on the relatively flat C1, C2 articular facets. From the C2-3 facet joint and below the superior facets are oriented primarily in a dorsal and cranial direction, whereas the inferior facets face the opposite direction. In other words, they are strengthening what I told you. It's a rondelle. They are faced in such a position, the facets, to hold the skull upright and to fix it to the axis below. The cervical spine is a mobile platform for the skull, and it is the most flexible portion of the vertebral column. Motion of the cervical spine includes flexion and extension, right and left lateral bending, and right and left rotation. In young adults, the normal neck motion is 70 degrees of flexion, 70 degrees of extension, 50 degrees of lateral bending, and 90 degrees of rotation to each side. Mind you, only 50% of these occur at the atlantoaxial joint, while the rest of the joints below the subaxial level have also some motion in flexion, extension, lateral bending, and rotation. The degree of motion between the two vertebrae is determined primarily by the orientation of the facets, how the vertebra above facet faces the vertebra below. Therefore, different vertebral segments contribute differing amounts to each plane of motion. This difference is particularly pronounced in rotation of the neck, where approximately 55 to 60% of cervical rotation occurs, as I repeatedly said, at C1, C2. Flexion relative to extension is limited at the occiput C1 joint, but from C1 to C6, the ranges of flexion and extension are approximately equal at each vertebral level. The total arc of flexion extension, however, is greater in the lower cervical vertebral segments, with peak motion occurring at C5, C6 level. Motion of the spine is often coupled. For example, lateral bending of the neck is accompanied by rotation, and the rotation of the cervical spine is coupled with lateral bending and flexion and extension. يعني كلهم بيمشوا سوا at times. For instance, also, the thoracic vertebrae, they have costal facets at the upper and lower edges of the junction of the body with the arch on each side. So these would limit the amount of motion of the thoracic spine, and it is mainly involved in lateral bending. If you look at the cervical spine of the thoracic spine, you have the sternum, you have the ribs attached to the sternum, and from behind, each rib is attached to the vertebra above and below. These limit motion in the thoracic spine. The superior articular facets are directed cranially, dorsally, and laterally, whereas the inferior facets point in the opposite direction. So, how is the motion in the thoracic spine? The primary motion in the thoracic spine is lateral bending and rotation. ليش؟ لما تقشع الفاسets in this direction. So it can bend in both directions and it can rotate. But for flexion and extension to occur, it is extremely
للاسف يا شباب التوقف من عند الدكتور جون عبد النور. احنا الان بنحاول نتواصل معه على اساس نعود للمحاضره.
اوكي هلا سامحيني يا جماعه. I apologize بس عندنا مشكله بالانترنت بلبنان وما وراء هالحاله بعتقد عاطله جدا،
اوكي
فبتواخذ
دكتور.
منكم كلكم.
لا ما في مشكله
اوكي
دكتور. اوكي دكتور.
يلا خليني بس share the screen. Oh, I hope it's working now.
Yeah, it's okay دكتور.
For how long, I don't know. So, flexion extension is the primary arc of motion in the lumbar spine, with greater movement occurring in the lower lumbar segments, mainly at L4-5. When the person is leaning forward, flexion occurs first in the lumbar spine, followed by rotation of the pelvis at the hip joint. When one goes from flexion to extension, it is reversed, with the pelvis extending first, followed by the lumbar spine. Motion of the cervical and lumbar spine decreases with age. We all know that. This decrease occurs sooner and is more severe in males. A bit about the intervertebral discs. We all know that the annulus fibers are the outer boundaries of the disc. It lies between both vertebrae, and it consists of the outer portion, which is elastic, and consists mainly of type 1 collagen, and the inner portion, which consists of water, proteoglycan, and collagen type 2. Now, this softens the area between two hard surfaces, which are the vertebra above and below. It acts as a shock absorber, and it takes a portion of forces off the ends of the vertebral body. In the young, it protects the vertebral body very well. In the older generations, they lose water and degenerate, and they protect the vertebral body poorly. And for this reason, many of the women who are osteoporotic can have compression fractures of the vertebral body, secondary to ineffective protection. So, we should also know that the intervertebral discs contribute approximately to 20% of the length of the cervical and thoracic spine, and approximately 33% of the length of the lumbar spine. Now, during the day, due to the loads and motion, there is loss of water. And therefore, if you measure the height of an individual in the morning and you measure its height at night, you see that there is a difference in height. Now, in the cervical and lumbar regions, the discs are thicker anteriorly. And this has some effect in taking part in the formation of the lordotic pattern. Cervical lordosis is secondary to the shape of the disc, but lumbar lordosis is the function of the shape of the vertebral body as well as the disc. Thoracic discs have a uniform height. Thoracic kyphosis occurs secondary to the shape of the vertebral bodies. The intervertebral disc includes the annulus fibrosus and the nucleus pulposus, which consists mainly of water proteoglycans and type 2 collagen, the annulus fibrosus type 1 collagen, the fibrocartilaginous inner portion, as I mentioned, is held together by type 2 collagen. Central nucleus pulposus, as I've repeatedly said, consists of water type 2, collagen, and proteoglycan aggregates. This composite structure provides good resistance to repeated loading in both compression and tension. With routine activities, compression pressures on the discs are balanced by a hydrostatic pressurization. It is a shock absorber by all means. There is something going on. The standard. شيء مش معقول اليوم. The negatively charged glycoaminoglycan molecules on the proteoglycan chains attract fluid into the extracellular space. Yani it imbibes water at night. The load at L3-4 disc ranges from 30 kilograms while the individual is lying supine to more than 300 kilograms when the person is lifting a 20-kilogram weight with the spine flexed and the knees straight. Even with excessive axial loading, the vertebral body and cartilaginous end plate fail before the intervertebral disc does. The discs also have a small concentration of type 3, 5, and 9 fibril-forming collagens and small amounts of 6, 9, and 12 short helix collagens. Type 6 collagen concentration is relatively high in the disc suggesting that this type contributes to the unique properties of the nucleus pulposus. During childhood and early adolescence, the nucleus pulposus occupies approximately half of the disc and has a large concentration of water, 70 to 80%, we love this question, of the weight, and proteoglycans, approximately 50% dry weight. The age-related changes in the intervertebral disc begins during adolescence. The initiating event appears to be diminished blood flow to the disc as vessels to the annulus and cartilaginous end plate become smaller with age and less numerous. Proteoglycan aggregates evolve into clusters of short aggregan molecules and non-aggregated proteoglycans. During the adult years, the nucleus pulposus becomes progressively smaller and more fibrotic as the proteoglycan and water concentrations decrease. The remaining peripheral blood vessels mostly disappear. Fissures and cracks appear between the lamellae in the outer annulus and progressively extend centrally. In the elderly individual, the disc inside the outer annulus evolves into a stiff fibrocartilage with few viable cells remaining in the nucleus pulposus. So, with age, we have many problems. The disc degenerates, the load becomes much higher on the facets, much higher on the vertebral bodies. The disc collapses. With time, the facets collapse, and you start getting all the problems that we will be discussing. Briefly about spinal mechanics, the axis of the thoracic and lumbar spinal motion is located in the disc, but the center of gravity is anterior to the vertebral body. Even with erect standing, a bending moment is generated in the spine that must be resisted by the intervertebral disc and the spinal ligaments and the spinal muscles from behind. So you have the nucleus pulposus is more or less anterior. So there is a tendency more and more for the whole body as a load to bend forward. But what resists them? It is the spinal ligaments, the discs, and the spinal extensor muscle. Greatest loads are seen in the lumbar region. The bending moment is markedly increased when an individual is lifting or carrying an object in front of the body, as lifting a دلو مي أو تحملوا شيء تقيل من قدام. You can imagine how much the load is on the disc. Flexion and torsional movement also greatly increase pressure on the lumbar disc. What about the physical examination before we go? When you're examining a patient, you should have an idea how to go in a relatively special way, going from up to down. Now, first of all, what you should know is where is the thyroid cartilage? Where is the hyoid bone? All these are important structures which will help us in the landmark as we are doing surgery on the neck. The hyoid bone lies opposite the L3 vertebra. The thyroid cartilage lies between the 3 and the 4 vertebrae. You should also know about the cricoid cartilage, which is at the level of C6 vertebra, and the carotid tubercle is also at that level. This would help us during surgery in every single way. When we're operating, we want to know the level. We can have an idea by palpating these structures. You should know the sensory nerve supply of each and every area of the upper or lower extremity. You should follow each of these nerves and memorize them. This is for the residents to know. You should also evaluate your patient well. You should be able to try and detect pain coming from the cervical region and pain coming from the shoulder region. In addition, you should see whether the patient has any difficulty in swallowing. Secondary, there has been reported in many articles in the Journal of Bone and Joint. One of them was by Sohail Boulos on cases where they had large ossified projections impinging on the esophagus and letting the patient have difficulty in swallowing. So it enters the differential diagnosis of these conditions. You should know about each of the C1, C2 vertebrae that we have discussed in detail. You should know how to examine the sternocleidomastoid, of how it arises from the mastoid process and inserts on the medial end of the sternoclavicular and the clavicle. You should palpate this because many times you have fibrotic tissue within it, especially in children that have torticollis. You should evaluate it. In addition, there are many lymph nodes in relation to it. So, in addition, you should examine the range of motion and whether the patient has any localized tenderness in them. Palpation of the occiput, because you can have irritation of the occipital nerve or the C1 and C2 nerves that supply the occiput, and you should palpate for these areas. You should do a range of motion of the neck in all directions to see where you have limitations. And you should evaluate the forces of flexion and extension. And by doing this, this is the position you should put the patient, put a hand on the sternum and ask him to push forward. And this will give you an idea about the flexors and vice versa, the extensors. Evaluate each of the motions and the strengths of each muscle. You should know that you have a recurrent laryngeal nerve that gives us a lot of problems in surgery if we don't pay attention to them, because we can injure them and the patient can end up hoarse. And you should know about the direction of each of the nerves. One rotates around the aorta at the lower end of the cervical spine, and the other rotates around the subclavian. And you should know where the position of this nerve lies on either side of the neck. You should examine for the motor function of the hands, because each of the motor functions would give us an idea about the cervical spine, what level. For instance, C8 neurologic level would tell us about the interosseous muscles. You can evaluate them because these supply, C8 supplies the interosseous muscles. You should be able to know at which level you have a reflex and when you don't have a reflex. Look at the sensation of C8 where it is. If the patient has lack of sensation, you should suspect something going on over here. In addition, you should do the Sperling test if you have a disc, and the way you can do it is by applying pressure on the head downward and turning the head to the side of the pain. And you will see that the patient will have much more pain by doing this. The opposite way is doing a distraction, and this decreases the pressure on the nerve root, on the disc, and the pain would say he feels better. You should observe the gait of the patient, see how he's walking. Each has a characteristic gait. The hemiplegia, the Parkinson's gait, where he tends to rush forward. Cerebellar ataxia, completely unstable, irregular gait. You should realize or observe the foot drop in case a patient has a drop, and a patient who has sensory ataxia is shown at each level. So you should examine your patient adequately. For the lower extremity, you should do a LASIK sign, which is not positive if it's more than 70. If it's less than 70 degrees, then you can depend on it. You should do the Hoover test. The Hoover test, the examiner puts both hands underneath the heels, and he asks the patient to raise his leg on one side. If he doesn't apply pressure on the opposite side on your hand, then he's a malingerer. You should also do the Milgram test. The Milgram test is on the extreme upper right. You ask the patient to raise both legs up, and if you have a patient with a disc problem which is radiating to that extremity, he will be forced to lower that extremity. Examine the range of motion of the back. What's important is on the left-hand side, as the patient's flexing, you should examine the distance from the floor to the tip of the fingers, or you should examine an extension. Any patient with a problem in the back, with a disc or tumor or infection, would have limitation, and as he's flexing for something which is important, which most probably he wouldn't be able to do it with ease, he will list to one side to avoid pressure in the area where the condition lies. You should examine ranges of motion in all directions. Likewise, force the patient to stand up straight, not moving, and rotate his spine. If he has any pains, particularly in the thoracic area where you have rotation and lateral deviation, if he has pathology, he will complain of pain. Know your sensory distribution of the lower extremity. Know what muscles exist. For instance, I'll tell you this. At the level of L4, neurologic level, we know that the tibialis anterior is supplied by that level. I'm sorry, these are simple, what I'm telling you, and I expect you to know them. So the tibialis anterior is supplied by L4, and the sensation is in the lower medial aspect, the front of the leg. And they have a reflex which is known as the knee jerk. So the sensation of L4, which is shown at the lower end and marked by stripes, this is the area. So if you're examining and you see that there's any deficit in this region, then you should know that there's a problem in the spine at that level. L5 nerve root, we all know that the extensor hallucis longus supplies the big toe, and if they have weakness or absence of dorsiflexion, know that the problem is between L5, L4-5, as the L5 nerve is involved. Likewise, you'll have loss of sensation or absence of sensation or decreased sensation in the web between the big toe and the neighboring finger or neighboring toe. In S1, you see that the sensation is absent or weaker on the lateral aspect of the foot, and they have weakness of plantar flexion of the toe, and they wouldn't be able to walk on the tiptoes. In the L5 nerve root, you'll see that these patients, if it's intact, they will be able to walk easier together with L4 intact on the heels. And that's why, while we're examining these patients, we ask the patient to walk on the heels and on the tiptoes and see whether they're weak or not. I want to finish with this before I go into the conditions. So you have the disc L3-4. We mentioned that at this level, it's the nerve below that is involved. Unless we have a lateral projection of a disc, then it becomes the same level. So this we don't want to discuss at this time. They will have, for an L4 nerve root involvement, the patellar reflex is declined, the tibialis anterior is gone, and they will have loss of sensation along the medial leg and medial foot. The L4-5, the reflex, it has no reflex, and the extensor hallucis longus is weak or absent, and they will have loss of sensation on the lateral leg and dorsum of the foot, while L5-S1, S1 Achilles tendon is the Achilles reflex is absent, the peroneus longus and brevis are weak, and for this reason we examine the foot to see the amount of force in valgus, how strong it is, and of course, you examine the sensation on the lateral foot. Now, there's an abdominal reflex. We would like to examine the superficial reflexes to make sure that they're intact. And we like to examine the cremasteric reflex by striking the medial aspect of the thigh, and the whole scrotal sac migrates superiorly. Of course, nobody should forget about the Babinski, which will tell you whether you have an upper motor or lower motor neuron lesion. Don't forget about the pelvis, people. Don't forget about the Faber test, which is the Patrick test. It means Faber stands for flexion, abduction, and external rotation test. As is shown over here, you put the foot on the opposite leg and you force it down by using your hand on the opposite side to hold the iliac crest. And this would strain the sacroiliac joint. And these patients will have either pain on one side, sacroiliac joint on the opposite side with pain. So the hip would be painful on one side and the opposite side, the sacroiliac joint. There's another method that we use to evaluate the sacroiliac joint, which is known as the Ganslin. We let the patient move to the tip of the table and we loosen and let his leg loose down. By doing so, you're rotating the sacroiliac joint. And if they have an infection or inflammation or any sprain, by doing this, as you're rotating the sacroiliac joint, the patient will have pain. You should know also that when you look at the behind of the patient and you see the dimple area, which is the posterior superior iliac spine, this helps us in surgery because if you draw a transverse line from the posterior superior iliac spine to the opposite side, it is S2. That's one. Also, if you go up to the iliac crest and you draw a line from the uppermost portion of the iliac crest to the opposite side, it will tell you the level is L4-5. And this helps us tremendously when we're operating for a disc rupture or protrusion. Another point to mention and stress is the LESEC sign. Don't call your attending and tell him, I have a positive LESEC sign at 80 degrees or 90 degrees. This is not a positive sign. At most, it should be positive between 0 and 70 degrees. Another important point, you should know about the cross-leg LESEC. This would tell you, as you're elevating one leg, the patient will complain of pain on the opposite side, which is the painful area. This would tell you that the disc rupture is most probably in the center. Don't forget to think about the pressure within the spinal cord. You should think about the Nafziger test and the Valsalva maneuver. Nafziger, you apply pressure on the vessels, both sides, and this will let the patient complain of pain in the lower back or in the back because you're increasing the pressure within the CSF around the cord, and this patient will have pain. Also, the Valsalva maneuver, don't forget to do it. Another point, you should be able to do the rock test for sacroiliac joint instability. Don't forget about the beaver sign. The beaver sign is very important because it will tell you about upper or lower motor neuron lesions and what level it would be. You ask the patient to raise his body as such, and you'll find that the abdominal muscles will move proximally in patients who have a problem. The reason why is because they have weaker muscles lower, and the stronger muscles are proximal. Therefore, it will tell you about the lesion injury or the lesion condition, whether it's tumor or infection or whatever it may be. So you have to go. This is called the beaver test. One should never forget to inspect the spinal alignment from the back and the side. From the posterior view, the spine should be straight. We all know this. Look for deviations in normal cervical and lumbar lordosis and for thoracic kyphosis. Loss of cervical or lumbar lordosis occurs with painful conditions such as acute sprains, fractures, infections, or neoplastic processes. The patient who leans to one side may be attempting to alleviate nerve root compression in the cervical or lumbar region. He lifts to one side to avoid pressure on the nerve. So you should look at the patient from behind. You can have an idea about the amount of lumbar lordosis. You can have an idea on whether the patient is kyphotic by looking at the patient from behind and from the side. You can have an idea about the position of the neck, especially in patients with ankylosing spondylitis, patients with rheumatoid arthritis of the cervical spine. They tend to bend forward. Examine the range of motion in all directions. And this is showing you a patient who is attempting to bend forward and showing the abdominal muscles. The whole umbilicus is moving proximally. So the muscles below the umbilicus are weak if the umbilicus moves proximally. It should remain in position. Don't forget about the anus. Don't forget about the bulbocavernous reflex. Don't forget about the perianal sensation. All these are important, especially in injuries or trauma. You have to examine these areas. When you get the patient, he may be in spinal shock, which we know it lasts between 48 and 72 hours. Usually it's 48 hours. Spinal shock is where the patient has no sensation whatsoever, then suddenly it recovers. The way you do it is by doing a bulbocavernous reflex. You put your finger in the anus and you apply pressure on the glans penis or on a catheter. And if it contracts, it tells you that the bulbocavernous reflex is intact. Now, also, don't forget, again, I've repeatedly told you about the neck range of motion. In all directions, lumbar flexion, asking the patient to touch the toes. Don't forget all these. I want to finally move into the condition. Observe the patient as he or she comes from a full flexion to extension. Indegenerate conditions frequently cause Rakiti-like motion as the spine moves into extension. Why? To avoid pressure on various areas in the degenerative spine. Okay. In addition, we have a special test from behind, which is called the Schoberg test, where you measure a distance from the sacrum up, which is, let's say, 15 centimeters, and you ask the patient to flex. As he flexes, if there is no increase in this distance, it tells you it's a rigid spine. But if it increases, then it is not considered a rigid spine. This is showing you of how you do the measurement. And then you ask the patient to bend forward. And if he flexes and their distance increases, it tells you that there's no paravertebral spasm. One should evaluate the sensory motor function of each cervical, as I mentioned this repeatedly. Don't forget about all these nerves. You have to have this table, memorize the area in which each of the nerves supply. Don't forget about the reverse straight leg raising, because discs, it's true that they occur most commonly between L4-5 and 5S1, but you have to think that certain discs do occur proximally. And the way you can examine this is by doing a reverse straight leg raising, by letting the patient lie on the abdomen and extending his rectus femoris. By doing this, you're extending the femoral nerve, and this will give you a positive sign if there's any pressure at whatever level. Now, one of the problems we're faced with is cervical myelopathy, and we have this problem mainly in the aged individual. As the aging process occurs, we know that there is degeneration, we know that there is a special joint which is called the sinoatrial joint or the synovial joint of Luschka. These are osteophytes arising from the posterolateral aspect of the vertebral body in the cervical spine, and these cause pressure, and as a result, pressure on the cord, they will end up having a myelopathy. And we are going to discuss this in full. But you have to know what the Hoffman sign is. The Hoffman sign is done by asking the patient to give you his hand. You, through the middle or the ring finger, you flicker it downward against resistance. And as you do so, you see that you'll have flexion of the tip of the ring finger, of the index finger and the thumb. They will move into flexion. Look at the diagram below. He's flickering the middle finger. You can do it for the ring of finger also. As you flicker it against resistance, this finger would flex, and the interphalangeal joint of the thumb will also flex. This is known as the Hoffman sign, and this is a sign of cervical myelopathy. There is also another sign of cervical myelopathy that we use is by asking the patient to extend his forearm forward, and as he does, the fingers are put together, and with time, the medial two fingers would deviate and flex. This is called the finger escape sign. A positive Hoffman sign is thumb and index finger flexion on the ipsilateral side. Superficial abdominal reflexes are assessed, again, as I mentioned it. Okay. We have gone through this. Now we come to the condition. I'm sorry I bored you a lot with the anatomy, with the physical examination, and with the mechanics. Now, with aging, what happens? With aging, we tend to lose water. We lose the collagen becomes dry, the proteoglycan becomes less and fragmented, the disc collapses. It no longer acts as a shock absorber. The fact that this collapses, the whole body will tend to move forward. And as it collapses, what happens? The load increases on the facet joint. As a result, these degenerate from the loads. And therefore, we begin to have problems in the lumbar spine, in the cervical spine, and rarely in the thoracic spine because they are supported by the ribs. Degenerative axial skeletal syndromes are endemic, with 25% of the adult population reporting neck pain and up to 80% experiencing low back pain. The symptoms cover a continuum from the aches associated with normal age-related degenerative changes in the disc to disorders that are extremely painful and disabling. Degenerative spinal disorders may begin during late adolescence. Isn't this surprising? At the late adolescence, in the mid-teens, but occur most frequently in middle-aged and older people. The clinical presentation varies from neck or back pain, with or without radicular symptoms, to disconcerting myelopathy. Disconcerting myelopathy. You don't realize how much the patient suffers from this myelopathy with extremity and bowel and bladder dysfunction. Most of the problems in the bowel and bladder that occur in the elderly are from the spine, from problems in the spine. Symptoms may coincide with well-defined pain pathways or may be vague and ambiguous. The latter symptoms are especially pronounced when the degenerative process stimulates macrophages and releases various cytokines that adversely stimulate nociceptive nerve endings in and around the adjacent spinal structures. Psychological symptoms are aggravated. How many people come with back pain who have psychological problems, and they may become paramount with persistent pain, inability to work at the usual occupation, the need to change jobs with subsequent loss of income, and litigation that may accompany motor vehicle injury or workers' compensation claims. Cervical degeneration syndromes, neck pain alone. Look at it. What can we have? We know that with age, you have a degenerative disc disease. We know that with motion, you have an increased amount of herniated disc depending on the load that you're giving. We know that there's secondary facet joint osteoarthritis. As a result, these produce bone. They narrow the canal, and as a result, we have spinal stenosis. Degenerative cervical spondylosis is a slowly progressive deterioration of normal cervical spine anatomy. It's a deterioration. Why? Because you have osteophytes occurring here and there. You have subluxation occurring here and there. It's changing the anatomy of the cervical spine. You have lordosis and it's changing the kyphosis. These osteoarthritic changes subsequently lead to increased mechanical stress at the discovertebral joints, the facet joints, and the spinal ligaments. As a result, bony overgrowth and ligament thickening can occur. These spondylotic changes can occur at individual disc space levels in the cervical spine in up to 40% of patients, and at multiple levels in up to 85% of patients. Traditionally, the most commonly affected levels are the disc between the third and seventh cervical vertebrae. Cervical spondylosis is a chronic condition with an insidious onset and gradual progression over time. In symptomatic patients, neck pain is the most common complaint. It may present as acute episodes or may be chronic. In patients with cervical facet joint pain, neck pain can travel along the spine. It can be confused with the shoulder girdle problem. And you can have that pressure on the occipital nerve. And these patients can present with occipital headache. Degenerative disc disease may present with broad symptoms. Why? Because it's broad. It's a broad changing of the whole anatomy. Patients will often complain of slowly progressive worsening of the neck with decreased neck range of motion, which is worst after a period of cervical inactivity. Morning stiffness and improves with mild neck activity, such as gentle, repeated neck rotation and lateral flexion. How many people wake up in the morning, the elderly, with stiffness of the neck or stiffness of the back after they walk for a motion and they move their neck a bit? The pain becomes less. Why? Because they have been stiff in an abnormal spine throughout the night. The degree of disc pathology seen on MRI does not often correlate with the pain. I would like to stress this. Many people, the very first time the patient comes to the clinic, they ask for an MRI. You have to examine your patient very accurately. And then you correlate the findings with the MRI. Many MRI findings are not the explanation why your patient came to you. Don't operate on the MRI. In 28 to 32% of patients, MRI findings are found, but they are negative. Many people have MRI findings of stenosis and pressure and etc., and never had pain. Keep this in mind. The majority of patients with degenerative changes on MRI remain asymptomatic for years. Cervical spondylotic myelopathy is the most serious and disabling progression of this disease and is traditionally characterized by clumsy hands and wide-based unsteady gait. I repeat, wide-based unsteady gait. They have clumsy hands. They hold the pen and it falls. They hold the structure and it falls from the hands. And it's most likely to be seen in the elderly individuals. Neck motion to the affected side is often limited due to pain. Decreased neck range of motion, typically worst after a period of cervical inactivity. Morning stiffness, alleviation of pain with mild neck range of motion, such as gentle, repeated neck rotation and lateral flexion. Most patients will display tenderness to palpation over the cervical articular pillars. When you're examining a patient, you should palpate. Don't be shy to palpate. Apply slight pressure. See where the area of pain which is localized. Always rule out signs of cervical myelopathy, such as upper motor neuron signs. Hyperreflexia, the biceps, the triceps, they are hyperreflexic. Do a Hoffman sign that I spoke about. Do a Babinski. Examine for ankle clonus and observe the patient when he's walking. You see he has wide-based unsteady gait. So the differential diagnosis for degenerative cervical spondylosis is rheumatoid arthritis affecting the atlantoaxial joints. We know that rheumatoid arthritis affects the upper joint much more than any. You have a synovial joint which is present in between atlas and axis. It's bounded by the transverse ligament. This can get inflamed and they will have pain. There's another condition that we don't like as spinal surgeons, is ossification of the posterior longitudinal ligament. Don't forget about patients who have fibromyalgia. Don't forget about them. They can confuse you. Also look for myofascial pain syndrome. And of course, cervical paraspinal muscle sprain and strains. Occipital neuralgia, as I've spoken so much about it, as a result of spondylotic changes, osteophytes, pressure on the nerve, and pressure on the nerve C1, C2. These will give you occipital headache. Degenerative shoulder pain. This is a problem. If you notice that you have a cervical problem, the pain is usually on the upper aspect of the shoulder. While if you have a problem in the shoulder joint, the pain is on the upper lateral aspect of the shoulder. But this is not always so. Primary spinal cord tumors, BS, extramedullary lesions. Don't forget about syringomyelia and normal pressure hydrocephalus. There is also conditions secondary to pressure, which would give you spinal cord infarction, spinal sepsis, whiplash injuries, and Pancoast tumors. Don't forget about these. Lateral x-rays of the cervical spine are usually adequate to appreciate spondylosis, especially at C5, C6, level. This is most commonly involved because the correlation between symptoms and radiographic changes is poor. Radiographs have limited usefulness in evaluation of clinical neck pain, but we should use them. We should not go directly to MRI. Take a simple lateral X-ray and an anterior posterior view. Another important point is in levels where you suspect that there is instability, you should take flexible flexion and extension views. This shows you a lateral X-ray of the normal cervical spine, and this is showing subtle lordotic curvature. Look at the curvature. Is it present? If it's straight, we say it's rigid along the posterior aspect of the vertebral bodies. On the other hand, if you look at this advanced degenerative condition of the cervical spine, there's loss of cervical lordosis. This is very important, especially if you want to do surgery on this patient. It will let you decide from where you're going to approach the patient. If you approach it from behind, the kyphosis will increase. So you have to pay attention to these. In the absence of systemic symptoms, such as fever or weight loss, trauma, or progressive neurologic symptoms, radiographs are typically not obtained until after 6 to 8 weeks of conservative management. Pay attention. If you have a patient coming with back pain or neck pain, by definition, you examine your patient and you depend on your knowledge of examination, your authority in examination. And it is recommended to have X-rays after 6 weeks if necessary. If not, then it's unnecessary. So you have to keep this in mind. Common findings in spondylosis are osteophytic changes, extra formation of bone at the end plates. The end plates is the superior and the inferior plates, platish covering of the body of the vertebra, with irritation, with failure of the discs. These irritate and they cause you to have posterolateral osteophytes, the sinoatrial joints, and these can be painful. They can press on nerves. They can give you problems. And they would narrow the neural foramen. MRI is the standard imaging modality for visualizing pathology of the intervertebral disc and is indicated in patients who have progressive neurological symptoms despite conservative management or in patients who plan to undergo surgery. MRI does have identified disease in most men and women younger than age 50 years, and in vast majority of people older than 50 years. MRI, a degenerative disc may display one of more of the following. They can have a decreased intensity on T2 weighted images. Why? Because we know that in young individuals, there are a lot of fluid within the disc, and the T2 is increased. With aging and degeneration and loss of water, there is a drop in the T2 weighted images, the intensity. Bulging of the annulus, hypertrophy, with or without intra-articular effusion. It tells us whether there is fluid collection in the facet joint. It tells us whether there is cystic formation around the nerves. Keep this in mind. A decreased intensity of cervical discs, increased signal of intra-articular spaces. It indicates effusion secondary to inflammation. Early changes of disc degeneration, such as tears of the annulus fibrosis, are seen on MRI. This is a lateral MRI of the cervical spine. It demonstrates narrowing of the spinal canal from C3 to C5 due to bulging disc and osteophytes at the interspaces. What about the treatment? Conservative management is the mainstay of treatment for patients who do not have neurologic symptoms and typically consists of physical therapy, non-steroidal anti-inflammatory drugs, muscle relaxers, and home exercise programs. Programs are directed at increasing cervical mobility. Narcotic analgesics may be used for short term, for 3 to 4 weeks, for intractable pain. Local intra-articular injection with corticosteroids or anesthetics can be considered for pain refractory to conservative management. The specific type of intervention is dependent on the etiology of pain and should be determined by a specialist. Thermal ablation or sensory articular branches of the cervical spine has demonstrated long-term efficacy in pain and functional improvement for majority of patients. Surgery is indicated for patients with progressive neurologic symptoms and compression of the spinal cord or spinal nerve roots. For neck pain without neural involvement, surgery is not typically indicated. Identifying a pathologic nidus is difficult when a patient's only presenting complaint is axial pain, and the only findings are limited range of motion and associated muscle spasm. Imaging studies may demonstrate narrowing and desiccation of the disc or the presence of facet osteophyte. However, the meaning of these findings is not clear because, depending on the age, 30 to 70% of asymptomatic people may demonstrate these changes. Most patients with axial pain can be treated successfully and non-operatively by modalities as such: pain management, short-term use of supportive orthotics, physiotherapy to strengthen paraspinal muscles, thereby diminishing stress across the degenerative discs and facet joints. Now we come to another section, which is cervical radiculopathy. Cervical radiculopathy is a clinical diagnosis that relies on detailed history and complete physical exam. Symptoms may begin insidiously without a clear time of onset or after an acute injury. It is important to determine if there was an injury at the time of onset, alleviating and exacerbating activities and or temporal association. Determining the presence or absence of radicular symptoms, such as radiating pain from the neck to the shoulder, scapula, or down the arm and upper extremity, with or without paresthesia, can aid in the diagnosis. Lower extremity weakness and hand wasting, with or without bowel and bladder changes, may be suggestive of the cervical myelopathy. So, if you have fever and acute weight loss and constitutional signs in the review of the system may require you to consider malignancy or infectious etiology, which will require further evaluation. Sperlings and the shoulder abduction test during the physical exam may be useful in detecting nerve root irritation. Flexion, extension, x-rays may be useful in evaluating alignment of stability of the spine. This is the shoulder abduction test. But many times you have patients coming into your clinic holding their arm like this. You ask them why. They tell you, we are relieved of the pain. By doing so, they're decreasing the pressure on the nerve roots. This is the shoulder abduction test. On vice versa, Sperling test, you're increasing the pressure on the nerve root plus the tension, and therefore you're producing pain. One, you're relieving the patient of pain. The other one, you're having more pain. So, MRI is superior to CT myelogram in identifying structural lesions that may accelerate or correlate to nerve root irritation. CT myelogram may be useful in evaluating patients when the MRI is contraindicated. Nerve conduction studies and electromyography, many times these are done by various doctors. These can be useful at distinguishing cervical radiculopathy from another disease process that may mimic similar symptoms, but a normal neurophysiologic exam cannot exclude the presence of radiculopathy entirely. Cervical selective nerve root block may be useful when radicular symptoms do not correlate with MRI imaging or neurophysiological findings, but the risk of vertebral artery infarction may outweigh any diagnostic benefits. Comparative cross-sectional ultrasonography of the cervical spine roots has been described in the literature, but at this time remains experimental. What's the differential diagnosis? Rotator cuff syndrome, myofascial pain syndrome, cervical facet syndrome, cervical myelopathy, and brachial plexopathy. Mononeuropathy, mononeuritis multiplex, CVA, multiple sclerosis, and transverse myelitis. What are the red flags, such as acute neurological deterioration and constitutional signs with bowel and bladder changes? Require urgent evaluation in the emergency department and possibly a joint neurosurgery consultation. Failure of acute medical management may require more invasive treatment options. So the way we manage radiculopathy is by conservative treatment. It's successful in 70% of the patients with cervical radiculopathy. In the acute setting, cervical immobilization with a soft collar for symptomatic comfort should not exceed 10 to 14 days. We don't like the cervical collar for long, but we like them to use them temporarily. For instance, working on a computer or going long distances in a four-wheel drive. All these will affect this constant motion and give you pain. Otherwise, don't use them during daily living. Initial medical management with non-steroidal anti-inflammatory drugs, acetaminophen, is recommended, although short courses of systemic oral corticoids are commonly used to reduce acute inflammation due to cervical radiculopathy. The adverse effects may outweigh any marginal benefit. Muscle relaxants, cyclobenzaprine, and tizanidine may be helpful in treating acute pain related to increased muscle tension and spasm, but long-term use may not show to be beneficial. Physical therapy may be initiated with range of motion exercises and passive modalities for symptomatic relief, and then progress to an individualized home exercise program with strengthening and stretching exercise. Traction and manipulation are thought to provide symptomatic relief by relieving pressure on compressed nerves, but the improvement is often short-lived and there are risks associated with each modality. In rare incidents, cervical manipulation may result in a stroke and vertebral artery dissection, and cervical traction can cause myelopathy. في صار بيعطوهم traction, which if you have a cervical myelopathy, they become worse with traction. If you want, you can use it at low, extremely low weight, but nothing else. Or spinal cord injury can even occur from it. Acupuncture may be a useful modality for symptomatic relief in cervical radiculopathy. Epidural spinal injection therapy may offer patient immediate and long-term improvements. Radicular symptoms, Sperlings, and shoulder abduction tests during the physical exam may be useful in detecting nerve root irritation. Don't forget these. Don't forget them. Flexion extension X-rays of the cervical spine are very helpful. They may be useful in evaluating alignment and stability of the spine. MRI is superior to CT myelogram, but they can be used when you cannot use the primer. Nerve conduction studies, I repeat. Cervical selective nerve root blocks, we spoke about them. So the take-home message, cervical radiculopathy is a referred neurogenic pain usually found in the distribution of a defined nerve root, but sometimes associated with brachialgia, diffuse non-specific pain in the arm. In the young, the usual cause is a herniated cervical disc that causes compression of the nerve root as it exits the foramen. Just look at them. Look at these tests. Look at the disc where it comes at posterolateral. We know that the disc projects usually posterolateral because you have a posterior ligament in the center. It prevents the disc from coming through this. It's usually posterolateral. In all the patients, entrapment of the nerve root is more often secondary to narrowing. Don't forget about the uncinate process or the synovial joint of Luschka or the sinoatrial joint. All these can cause pressure. A typical symptom is pain in the neck paracervical region that radiates in the dermatomal distribution of the extremity. Don't forget about occipital headaches, weaknesses. All these are important. So I'm going to go very quickly through these because these are repetitions. Okay, now, operative treatment is indicated for persistent disabling symptoms. Disc excision can be done by an anterior or posterior approach. However, most patients are treated via the anterior approach with decompression of the disc and concomitant arthrodesis. Spinal fusion prevents the potential problem of cervical instability, and by placing an autograft or allograft, appropriate size, or a cage, the height of the disc space and foramen can be restored. So don't forget about cervical myelopathy that goes through the aging process. This is taken from Nabil Ibrahim's series of slides speaking about cervical myelopathy and pressure on the cord. So, and he speaks about the best test is the MRI. So don't forget about these. So I would like to mention something. In the Asian population, yani the Japanese, for some reason or another, we have a high incidence of ossification of the posterior longitudinal ligament in this population. The natural history of cervical spondylotic myelopathy results in progressive neurologic deterioration that is frequently recalcitrant to non-operative measures. Surgical management, on the other hand, can often successfully halt, potentially reverse patients' neurologic decline. Thus, operative management is the standard of care of patients with moderate to severe myelopathy, the choice of which operative procedure to perform is a complex issue that must be determined based on the patient's individual symptoms, radiographic findings, and risk profile. Cervical myelopathy is a syndrome of clinical findings, and you have developmental stenosis, degenerative stenosis, and calcification. Congenital cervical stenosis is a condition which is well known, and this is known to occur in certain conditions like achondroplasia, where you have a very narrow canal, and this can promote cervical myelopathy at an early stage in these patients. Okay, another condition where they can have is hypertrophy of the ligamentum flavum and facet joint laxity. So the aging process is very important. We spoke about this in detail. We spoke about many of these. There is a classification which Nirac put, and he claimed that as you increase in the number of grades, the worse the prognosis is. There is a strong advice about the degree of involvement and about the result in patients who have spinal stenosis. It has been hypothesized that these exacerbations may trigger minor traumas. While this has supported by the literature in the setting of patients with OPLL, a recent systemic review found insufficient evidence to support or refute this claim in patients with either asymptomatic spondylotic cord compression and myelopathy in the absence of ossification of the posterior longitudinal ligament. So I'm going to go quickly through these. You have to really know about the neurologic status at each level. In the final stages, they have sphincter dysfunction, unable to void, marked difficulty in micturition, minor difficulty, etc. There's a scoring system in reporting the degree of involvement. So I want to go through this very quickly. Let's see. We've spoken about all these so many times, spoken about this. I want to just mention that patients with cervical spondylotic myelopathy have a particular type of gait. You see that the gait is wide. They have a dropped foot gait. They are very unstable on their extremities. So that's what I would like to mention about. Okay, and let's see. Don't forget that you can have stenosis at multiple levels, not only concentrate on one level. You have to concentrate on many levels if the patient has the signs and symptoms. Now, the patients that you operate on You have to evaluate them fully. You should make sure that the comorbidities are minimal. You should make sure that they are not at risk. You should have an adequate amount of blood. You have to be sure that your patient can tolerate the operation. These operations are major operations. Okay, so now I would like to mention briefly about Pavlov ratio. Pavlov ratio is a ratio that tells us about stenosis. We measure the distance of the posterior aspect of the vertebral body to the spinal lamina junction and divide it by the distance from the anterior to posterior surface of the vertebral body. This should be more as 0.8 or more. Otherwise, your patient has spinal stenosis. This is showing it over here. Okay? 0.8 is the limiting grade. Don't forget about all these structures I mentioned about the disc, the osteophytes causing canal stenosis. You have to pay attention. Instability. All these act and give us spinal stenosis. Now, what can we do for them surgically? Now, if you go in and operate and do a laminectomy without fusion, this is very bad. Why? Because they will go into kyphosis, and we don't like this. We don't want it. Always, when you do a laminectomy, it should be done with a fusion. There's a technique which is called the laminoplasty, which is an open book lamina of the vertebra. You see over here, this is the lamina. We cut the lamina from here, and over here we cut only one cortex, and then we divert the whole lamina laterally. In the past, we used to use a suture to hold this. Nowadays, we have a particular plate that we can put from this area to this area. The rationale is that in cervical spondylosis, myelopathy, if you fuse, then you have a very stiff neck, and then you'll have problems. This rationale of laminoplasty was created so as to maintain a cervical spine that is mobile. Now, on the whole, if we have lordosis, and there are multiple osteophytes from the front, we like to operate from the front. At times, we have to remove the vertebra completely, put a cage in, or expandable cage, or and the plate. But we should aim at removing any discs, any osteophytes from the front. Now, from the posterior aspect, either laminectomy and fusion or laminoplasty. Now, there is another method that we do. It's called the French method, where we do our osteotomy over here and we open the spine. This is the French method. This is how the osteotomy was done here, and the whole lamina is elevated like this, and we put either a suture from here to here, or we put the plate from here to here, to the lateral mass. This shows it to you on a model. Likewise here. Okay, this is a laminoplasty done at multiple levels. We aim at expanding the canal. We aim at expanding the canal. Now, at times we can go from behind and then go from the front to stabilize the spine from behind, and then go from the front to remove these osteophytes. These are multiple techniques. This is one where the problem was approached both from the front and behind, and any osteophytes were removed. Why? Because this patient had this kyphosis. If you go totally from behind, it will go into flexion further. So what we do, we go from the front, we remove the vertebral body, and then we can put a cage or put multiple cages, or an expandable cage and a plate together with the posterior translateral mass, screws, and all. This is another case. This is a third case where it's done from the front. You can see the cord where it lies. These are nowadays, there have been a rush into discoplasties. Well, these can be done in early cases where the condition between the vertebrae are not so aggressively. But the advantage is you can maintain the motion in a discoplasty. But at the risk, if you have an infection, it's a hell of a job to remove the material. 2, you have wear debris, and you don't know what the future is going to be with time. But we have had long-standing cases that were done, and there was no change, and the patient was quite happy. But on the other hand, we don't want to cheat you. On the other hand, we have had cases where the patient was very unhappy. So you either can do a laminoplasty, do a laminectomy combined with the fusion, do a anterior fusion following doing a corpectomy and removing multiple osteophytes. One warning I would like to tell you: if you have a patient who has ossification of the posterior longitudinal ligament, this is a warning I would like to tell you. Try and avoid going from the front, because there is a lot of adhesions between the calcified ligament and the surrounding dura. And many times when we tried to remove it, we would get tears in the dura, and it is a hectic job to try and deal with these conditions. So when you have ossification, which is massive, of the posterior longitudinal ligament, try and go posterior. Okay, another point: when you're going from the front and you're putting a plate, don't over distract the vertebra by putting a cage or bone graft. It's true you will be opening the canal, but you will be straining the nerve roots, you'll be straining the cord, and the patient will become worse. Another point: when you're operating from the front and you remove the osteophyte and you want to put the plate, you should put the plate close to the ends of the adjacent vertebra. Don't put it too far superiorly or too far inferiorly, because this will promote an adjacent disc disease at a later time. Another point: if you want to detect the level of the tension, don't go around pinning or using a needle within the disc of the adjacent levels, trying to see at what level you are and asking for a fluoroscopic view. Now, by putting a pin in a normal disc will provoke a later degeneration of this disc. Look at this diagram. You see the plate, how it's put. It's put at both adjacent tips, and the screws are put at both adjacent tips. Keep this in mind. Okay, so if pathology extends above or below the disc, anterior cervical corpectomy and fusion should be done, because the surgeon cannot safely address this pathology through the exposure afforded by a discectomy alone. Extensive multi-level anterior pathology can be seen in OPLL, ossification of the posterior longitudinal ligament, as well as spondylosis. Due to the limitations of exposure and technical challenges with multi-level fixation and fusion, a combined approach is recommended when addressing pathology at greater than 3 levels, requiring anterior decompression. Summary. This way, it would put us an end at the cervical level. Cervical spondylosis with myelopathy can be extremely disabling. Cervical myelopathy may be caused by a large central disc herniation, but most commonly it is due to severe spondylotic changes, including stenosis of the canal from ingrowth of bony spurs, as well as thickening and buckling of the ligamentum flavum. This shows you the stenosis that we have spoken so many times about. The condition, I said, is more common in men than in women. And we spoke about rheumatoid arthritis, trauma, and metastatic spine disease can cause it. So you have to keep in mind that you would have stiffness, and in patients, you can have progressive sensory abnormalities in the upper extremities. They lose objects, don't feel normally, and they will have progressive motor weakness, spasticity, and loss of proprioception of the lower extremities. That's why I showed you this gait, this kind of unsteady gait that they have. Okay, so don't forget these points. These are very important. So now I was asked to give the particular indications for cervical myelopathy. The indications for surgery include progressive neurologic deficits, a static neurologic deficit associated with radicular pain that does not respond to non-operative treatment, and a stage reached in the patient in accordance to the neuroclassification, which is progressive, then you should go ahead and do operation. Many of these patients were tried to be treated non-operatively. They go through a stable period, but then if they change into an aggressive instability, then the prognosis becomes bad. Most of these patients should be operated early. Okay, don't forget about this. Now we can go to back pain very quickly, and then I want to go into tumors because I want to show you two techniques used in the resection of tumors of the spine. One is by Ehud Mendel, who's very famous, and another is by surgery done in Russia. So I would like to show you these, but let me go through these very quickly. Low back pain with or without leg pain is very common, particularly in middle-aged and old adults. Degeneration of the intervertebral discs and some degree of low back pain and stiffness are universal with aging. Degenerative discs end up with decreased height, increased posterior and lateral bulging, reduced ability to dissipate compression forces. We all mentioned these before, and initial increased mobility. Don't forget this. Abnormal loading of the facets, we spoke about it, greater stresses on the ligaments, and there is a tendency for the patient to move forward. He will have a positive sagittal balance, and this with time will progress. Chronic low back pain is defined as persistent symptoms for longer than 6 to 8 weeks and is common among people older than 40 to 50 years of age and those working in occupations that require frequent bending and lifting, or exposure to repetitive vibration. Obesity and poor physical fitness also results in back pain. Smoking does increase the chances. Driving in a car, four-wheel drive, with multiple holes in the streets can provoke back pain. Truck drivers are predisposed to have back pain. So the pain starts in both buttocks, it starts in one leg and then moves upward. Flexion of the spine and straight leg raising are mildly affected. With more severe involvement, extension of the spine causes increased discomfort and dysrhythmic or rackety-like motion. All these are affected. So I'm not going to go very slowly in these. We spoke about the reduced height of the intervertebral disc. We spoke about osteophytes. We spoke about hydration of the disc. And we spoke about inflammatory conditions, especially in the cervical spine. We spoke about the MRI and significance of making a diagnosis. So the differential diagnosis of chronic low back pain, the intraspinal source is a degenerative disc changes and herniated disc, or degenerative spondylosis, lumbar stenosis, and intermittent neurogenic claudication. Coda-Equina syndrome. Mind you, a Coda-Equina syndrome for the junior residents is a disc which occurs centrally at the level of L4-5 usually, and it presses on the nerve roots. As a result, they will present to you with difficulty on passing urine and stools with intolerable type of pain, and this can be an emergency. Osteomyelitis, epidural abscess, discitis enter the differential diagnosis of low back pain. Neoplasms, whether it's primary, metastatic, inflammatory arthritis, osteoporosis with compression fracture, musculotendinous insufficiency. Other sources, beware of vascular insufficiency. Beware of abdominal aortic aneurysm. Beware of gynecologic problems, ovarian cysts, endometriosis. Be aware of intra-abdominal and intrapelvic tumors, sacroiliac arthritis, arthritis of the hip. Many patients have been operated on for a spine, but later on they found that they had arthritis of the hip and referred to the orthopedic surgeon. So recurrent episodes of pain are typical, but most can be managed conditioning exercises, abdominal and paraspinal strengthening exercises, weight reduction, and cessation of smoking. So don't forget about this. Unremitting pain necessitates further evaluation. Operative treatment may be indicated, but the results are not always successful. The advantages of and the indications for various operative techniques include posterolateral fusion with or without instrumentation, intervertebral disc space arthrodesis and bone graft, and artificial disc implants. So the herniated disc, we all know that it can be protruded, extruded, or sequestrated. This shows you each. If it's sequestrated, meaning that the disc material is away from the source of extrusion. You have to realize many times we are asked, the patient, when he has a disc and he rests for 2 to 3 days on anti-inflammatory drugs, muscle relaxants, and painkillers, the pain goes. If you do an MRI, you'll find that the disc is still present. What does this tell you? It tells you that there are various cytokines released from the nucleus pulposus that cause an inflammatory response leading to pain. When these go, the protrusion does not go, and that's why you see it on MRI, and the patient is relieved of the pain. So, more than 90% of lumbar disc herniations occur at the posterolateral region of L4-5 and L5 and S1, with subsequent compression of L5 and S1 nerves, respectively. Of course, lumbar nerve roots emerge from the canal at the superior aspects of the foramen and posterolateral herniation that compresses the next lower nerve root. A far lateral disc herniation at L4-5 and L5-S1 compresses L4 and 5 nerves respectively. You see, it's the far lateral will compress the disc and be compressed from the disc above. Otherwise, if it's not a far lateral, then it's compressed from the disc, lower level. If you have an L4-5, L5, L3-4, L4. Pain is increased by sitting, sneezing, and lifting, and is decreased by lying down with a pillow under the legs, by lying on the side with the hips and knees flexed. This we know. Symptoms are variable, but L5 entrapment pain radiates to the posterolateral aspect of the thigh we spoke about, the posterior calf, and the medial aspect of the foot. And you see that the sensation is decreased in between the big toe and the neighboring toe on the dorsal aspect. S1 is on the lateral side of the foot, and the plantar flexion is decreased. So you have to know about these positive straight leg raising tests, the cross leg sign that we spoke about in the physical examination. We spoke about the reversed LESEC, which is known as the rectus femoris test. You have to know about these nerve roots, the sensations. Radiographs of the lumbar spine are normal but should be obtained to rule out other conditions. That's why we ask for radiographs. Please don't ask immediately for MRIs. Look at the bone, see what's going on in the bone. MRI gives you a very clear picture about the nerves and soft tissues. Don't forget the radiographs. They occur first. You should ask them as a first line of management. Okay? So these are points you should know. The indications for surgery include the Cauda equina syndrome, patients who have urinary retention, progressive neurologic deficits, severe single nerve root paralysis, radicular symptoms that show limited progress for longer than 6 to 12 weeks, and recurrent sciatica that compromises the quality of life. The goal of the operative procedure is to alleviate pressure. The procedure usually involves a small laminotomy and excision of the herniated disc with or without magnification. Other methods include percutaneous discectomy by suction or endoscopic techniques. These show you the various types of disc hernias that occur. So, lumbar disc surgery is to relieve the symptoms. And if you have recurrent disc herniation occurs following this, you have to explain this to the patient that once you do the surgery, doesn't mean that the patient should jump around. There is a chance that it will recur. You have to know that if you're not a good surgeon and not extra careful, you can injure the neural elements. Another complication is postoperative septic discitis. Victor Mature was a famous actor. He had an L4-5 disc. The surgeon decided to operate him. Throughout, as he went in the space, he went through the posterior aspect, through the anterior aspect of the disc. And what did he catch? He caught a blood vessel, and he had bleeding, and he died. This is a known complication. I know of one case that they were operating and they removed the appendix by mistake throughout the disc space. Another problem with this, if you don't operate on the proper level, you can miss it. You can miss the surgery, especially in sequestrated discs, and the patient would have persistent pain. This is a patient who has a coda equina syndrome, a huge disc at the level of L4-5, and it is central. So it may be compressed relatively a short time by a central disc herniation or other condition, such as an epidural abscess or epidural hematoma or fracture. Midline sacral nerve roots that control bowel and bladder function are particularly vulnerable. Symptoms include bilateral lower extremity radicular pain, motor or sensory dysfunction, saddle anesthesia, difficulty voiding or loss of bladder and anal sphincter control, lower extremity pain and weakness are typically more severe in one leg. These are indications for acute release of a central disc having coda equina signs and symptoms. Patients with coda equina syndrome usually require urgent surgical decompensation or decompression. Even with prompt treatment, however, the return of neurologic function is often incomplete. Lumbar spinal stenosis results from any condition that causes narrowing of the spinal canal and subsequent compression of the nerve roots and one or more levels. The most common cause is degenerative changes, often combined with some degree of spondylolisthesis. Patients with achondroplasia, I mentioned this, or other conditions that alter growth of the posterior arch may develop stenosis and progressive symptoms in the second or third decade. You can see that these patients who have congenital stenosis, these signs of stenosis occur at a much earlier time. Other causes of lumbar stenosis are secondary to traumatic or post-operative changes. They can be iatrogenic. This tells you about the stenosis, and look at the canal on the left side of how narrow it is. The pressure can be from behind or from and the front. An enfolded ligamentum teres can result in stenosis. Approximately 20 to 30% of those older than 60 years have narrowing of the lumbar canal, but most persons are minimally symptomatic. Skeletal changes associated with stenosis in the older population include degenerative changes and osteophyte formation at the facet joints, osteophyte formation at the lamina, narrowing of the disc, and spondylolisthesis. Soft tissue changes associated with stenosis, as I mentioned, the ligamentum flatum, or ossification of the posterior longitudinal ligament, herniation of the disc, arterial diseases, smoking, multiple levels of compression and duration and severity of compression cause progression to neurogenic claudication. Symptomatic lumbar stenosis is common among men older than 60 years who have performed heavy manual labor. Typical symptoms are radicular and progress in proximal to a distal direction. Back pain is not prominent and may be absent. Symptoms are often bilateral, but more severe in one extremity. Patients note discomfort and progressive weakness. You notice that these patients have a tendency to flex the spine. Why? Because the canal widens and opens. So you have to keep this in mind. Vascular claudication. You have to differentiate it from neurogenic claudication. Vascular, you have a fixed as opposed to a variable stenosis claudication distance. They have an increased pain while using the stairs or walking uphill, while the others are decreased while walking uphill. Why? Because you're flexing the spine. Rarely they have back pain or weakness with vascular claudication, and typically demonstrate loss of peripheral pulses and calfea. If you look at the leg of a patient who has vascular claudication, you see that there is no hair present. Lumbar extension may be limited, but is often normal for the patient's age. Muscle weakness is often subtle and may be elicited only on a treadmill testing. Radiographs often show degenerative diseases, which is most common at L4-5 and L3-4. So the differential diagnosis is arterial insufficiency, patients with diabetes mellitus. Beware of an abdominal aortic aneurysm. I will tell you a simple case. I had a woman come to my clinic complaining of back pain. On examination, her back findings were insignificant. But while feeling for her pulses, I felt a pistol pulse in the area of the posterior tibial artery and the dorsalis pedis. I borrowed a stethoscope and put it on the lower abdomen, and I heard the bruit. The clinic next door was a vascular surgeon. I thought, wait, you go to him immediately, and he should carry on the treatment immediately. She went out of my door and was going into the other patient's door and collapsed. She had a rupture of an aneurysm at the bifurcation of the aorta, and she passed away. So you have to be very careful from these cases. Diabetes mellitus, as I said, have back pain and leg pain, abdominal aortic aneurysm, I spoke about, infections or tumors, vitamin B12, and folic acid deficiency. Non-operative management include weight reduction, cessation of smoking, lumbar flexion exercises, bicycling, avoidance of activities that extend the spine, intermittent use of non-steroidal anti-inflammatory drugs, and empiric use of folic acid. All these are very important. When symptoms are persistent and disabling, operative therapy should be considered after evaluation by MRI or computed tomography scanning with contrast has been completed. The principles of operative therapy require adequate decompression of the neurostructures. And when instability is created by complete removal of a single facet joint, removal of more than 50% of both facets, or removal of more than 1/3 of the pars interarticularis bilaterally, don't forget, you need a concomitant fusion. This is various procedures that we do. And if we have to remove a sufficient amount of the facets, we do a fusion. The surgery is most successful in patients with persistent and incapacitating neurogenic claudication. Surgery is less successful in patients whom back pain is the predominant symptom, and those with comorbidities such as smoking, obesity, or diabetes mellitus, recurrent stenosis may occur. Degenerative spondylolisthesis, just briefly speaking about it, it's most commonly to involve the L4-5, and by slipping you get narrowing, you get stenosis, and as a result, you get pressure on the nerve roots. Sorry. Spondylolisthesis is translation, slippage of one vertebra in relation to the adjacent segment. The superior vertebra typically slips in an anterior or forward direction, but retrolisthesis may occur particularly in degenerative spondylolisthesis at the upper lumbar levels. The causes of spondylolisthesis vary, but most patients have either an isthmic or a degenerative type. This is a degenerative type. You don't see any isthmus, fracture, or insufficiency. It is a pseudo spondylolisthesis. This occurs in degenerative processes. Look at the disc. The disc is narrow, so the support is gone. As a result, the vertebral body will slip forward. But in degenerative cases, it does not slip more than 2 types. We know we classify spondylolisthesis into 5 types. One, according to the percent, 25% slip, 50%, 75%, and 100%. And there is a condition which is called spondyloptosis, which is a complete slip. If you look at the X-ray on the right hand, you see that there is a retrolisthesis at the upper level. So slipping of the vertebra can occur in various directions. Now, what are the types of spondylolisthesis? We have type 1 is a dysplastic. You have a congenital incompetency at the lumbosacral junction. Type 2 is a stress defect in the pars interarticularis with attenuation of the pars interarticularis. And C, you have a fracture of the pars. Then you have to think of degenerative, where I spoke about, and you have a segmental instability. 4, you can have a traumatic. And 5, you can have a pathologic. It can be metabolic, it can be secondary to tumor or fracture. And 6, it's post-surgical. it's iatrogenic, where you have removed too much of the facets. You didn't even do a fusion, and so this could slip. And that's why I stress so much that you should do a fusion. So these are what you can do, but don't forget to do a fusion. If you remove more than 50% of the facet, you create an instability. You have to do a posterior or posterolateral fusion. In degenerative spondylolisthesis, the neural arch is intact, but erosion and narrowing of the disc and facet joints lead to segmental instability. There is no defect. It starts in the disc, it ends in the facet, and finally you have instability and slippage. This occurs in older adults and is more common in women and blacks, and is most common at L4-5 level, probably because of a combination of factors, including degenerative changes and stiffness at all levels, the relative coronal alignment of the facet joint at L5-S1 level, resultant force, concentration on L4-5, which is more sagittally aligned, and diffuse. It can occur at other levels and may be seen at multiple levels, resulting in cascading. Don't forget, cascading, meaning that you have multiple level lesions and compressions, and this can lead to symptoms and lead to your problems. As a result, you can have back pain, radicular pain, neurogenic claudication, and the indications for surgical management are intractable pain, severe myelopathy, and Cauda-Equina syndrome. They all apply. If you notice, from the very beginning that I spoke you to now, it all, if surgery ends, it's due to narrowing and impingement on the structures. Because of concomitant instability, decompression usually is combined with arthrodesis. Instrumentation enhances the rate of fusion. Decompression alone or decompression and fusion without instrumentation, pay attention, without instrumentation is indicated only in an elderly patient with virtually no disc remaining. Why do we say no disc remaining? Because when the disc goes, it becomes flat, and the vertebral body will lie on the neighboring vertebral body. The chances for it to slip is much less. Okay? So I want to be clear about this. Scoliosis in adults. There are two types of scoliosis. One is the remnants of an adolescent scoliosis that occurred at a young age. And scoliosis is defined as it's a tridimensional. There is a rotational effect, there's a lateral deviation, and there's an anterior problem, such as sagittal imbalance. It's a tridimensional. Now, any change in these things lead to scoliosis, especially if it's more than 10 degrees. What we mean about 10 degrees, the Cobb measure. This can continue into adult lives. There are certain curves which can progress, especially thoracic curves, which are more than 75 degrees, or lumbar curves, which are more than 30 degrees, Cobb measures that would progress. These can progress. You have to follow them up continuously because they can give problems in the future. There is another form of scoliosis which is called de novo scoliosis. And this occurs secondary to osteoporosis, degenerative arthrosis. All these put together will end up in scoliosis. This is the adult form. And let's see, progression, we spoke about 30. The thoracic, we spoke 50 to 75, and the lumbar, 35. We spoke about osteoporosis and degenerative conditions leading to it. This would lead to pain, and it's multifactorial, and they will end up having trunk imbalance with subsequent muscle fatigue. They have facet disc ligament overload. They have osteoporosis and spinal stenosis. They can have, of course, secondary to pressure. They will end up having a radiculopathy, which is more common in patients with degenerative scoliosis. Why? Because you have the osteophytes. You can have patients who have adolescent scoliosis that had progressed but never had any pain. Significant pulmonary dysfunction is unlikely unless the patient has comorbidities such as excessive smoking or pre-existing pulmonary disease. Non-operative management of painful scoliosis is similar to management of other chronic spine conditions. The indications for surgical management include intractable pain or structurally significant curves with documented progression. Operative management includes stabilization fusion with segmented fixation that provides stability for early ambulation. Now, let me tell you, there are several articles that have been written where they say in the degenerative scoliosis, if a patient has symptoms, just operate minimally, remove the area of pressure, which you presume by diagnosis and by clinical findings and by lab findings and by radio imaging to be the level, and that's it. Don't do more than what is necessary. Decompression of spinal stenosis also may be necessary. The rate of major complications is much higher in adults than in adolescents. That's why I told you try and do the minimum. Possible adverse outcomes include pseudoarthrosis, persistent pain. There's nothing more miserable than a patient who comes to your clinic and say, I did not improve following the surgery. They have a higher incidence of thromboembolism, neurologic injury, infection, and mortality is much higher. What about spinal trauma? I want to read the tumors very quickly because I have two films. I want to show them to you. Dislocations and fractures of the spine can be devastating injuries. Most such injuries result from motor vehicle accidents or falls from heights. Neurologic injury may occur and may be transient or result in permanent deficits, including quadriplegia and paraplegia. Chronic pain and disability also may occur. Most fractures and dislocations can be classified into one of 6 mechanisms: compression flexion, vertical compression, compression extension, distraction flexion, distraction extension, and lateral flexion. Fractures usually result from vertical compression, axial loading, or compression flexion. Dislocations most often result from distraction flexion. Pain, tenderness, and paraspinal spasm are typical symptoms. Radical symptoms suggest isolated nerve root or coda equina compression. More global motor and sensory abnormalities suggest spinal cord injury. Palpate the spinous processes for abnormal alignment, suggesting significant injury. You can feel a gap. You can feel that one spinous process is deviated to one side. Examination should include the evaluation of all nerve roots distal to the injury. Don't forget about what I told you on physical examination, perianal sensation and sphincter tone. Don't be ashamed to put the finger in the anus and squeeze the penis or apply stress on a catheter or apply traction on the clitoris. Don't be ashamed. You should not miss anything. Sparing of S24 functions may be the only early indication of a partial spinal cord injury. Initial radiographic studies to the cervical spine injury include the anteroposterior, the lateral. These should be done at multiple levels in multiple injured patients where you suspect the spinal injury of the cervical, the thoracic, the lumbar spine. Odontoid views, open mouth views can be difficult. Inadequate radiographs may miss upper or lower extremity, lower cervical. Lateral views must include the occiput down to T1. I've seen many fractures missed at the level of C7, T1. Why? Because the shoulders are in the way. You should apply traction. And thanks to CT scans, they help us in detecting these injuries. Study the radiographs for signs of significant injury, such as more than 7 millimeters of soft tissue swelling anterior to C3 vertebra. You have to know about the thickness of the soft tissues in front of the cervical spine, or disruption of the normal lordotic line of the posterior vertebral body. We know that there are several lines. You have the anterior vertebral line, you have the posterior vertebral line, you have the spinolaminar line. If you have any disruption of these, it tells you that there is an instability. And this is indicated, especially in the cervical spine, by displacement of the vertebra above on the one below by 3.5 millimeters and an angulation of 11 degrees on the lateral radiograph. You see that the lateral radiograph is important. Or by malalignment of the spinous process. You see in one view that it appears as a localized oblique view when you're taking a lateral view of the cervical spine. You have to know how to read your radiograph. These are radiographic signs of the cervical spine, of how one moves on the top by 3.5 millimeters and the angulation of 11 degrees or more. A CT scan should be obtained when plain radiographs show abnormalities or when patients have severe trauma or pain. MRI study is performed when the injury may be associated with disc extrusion, lateral flexion, extension. Radiographs may be helpful, but only after muscle spasm has abated. Initial radiographs for the thoracic and lumbar injuries include anteroposterior and cross-table lateral. We spoke about this. CT scans and MRI are all important. Don't forget about the ABCs when you get these injuries, they're severe injuries, and you should pay attention as you're moving these patients about as a log roll, multiple people. Now, there is in the emergency room of many institutions a CT scan that rotates, and this can take multiple views, put the patient in the same position, and it relieves you as to rule out any fracture. So the cervical fractures, don't forget about the Jefferson fracture. I'm going to go very fast. Jefferson fracture is secondary to axial compression, and as a result, any of the walls, that surrounded by the anterior, posterior, lateral walls. And when you have a force coming, it expands the canal. We rarely see a neurologic injury with this type of fracture, the Jefferson fracture, and it's secondary to axial compression. The space is not compromised. Now we have odontoid fractures. We spoke about the three types of odontoid fractures, which are at the tip, at the waist, and in the body. At the tip, it's the alar ligaments of the odontoid that pull it out. We have three ligaments around the odontoid: the transverse, we have two alar ligaments, and we have an apical ligament. So when you have an avulsion at this level, the alar ligaments pull it out. In the waist, the problem is we believe that the waist is a watershed area. There is little periosteum. And when you have a fracture with minimal displacement, such as a few millimeters, this will provoke it to have a non-union. And for this reason, we like to operate them. Then you have the third type of fracture of the odontoid is in the body. There's a lot of cancellous bone. These do unite. Now, the fall, the result of this fracture is from an impaction, either in the anterior or the posterior occiput, leading to this fracture. The transverse ligament presses on the odontoid, or the anterior arch of the atlas impinges on the odontoid, causing these fractures. Then you have a hangman's fracture, which occurs at the level of C2, which occurs in the pars, and this occurs secondary to a flexion extension injury at that level. All these can be treated conservatively, except in the type 3 hangman's fracture, where you have a fracture dislocation of the facet. So you have to operate. Now, a warning of these fractures of the Jefferson, you have other conditions associated with it. You have to rule them out. So be very careful about this. If you look at how would you tell from a plain X-ray that an odontoid is fractured? If you look at this AP X-ray, you see that there is symmetry between the facet joint, and the odontoid is localized within the center. Now, when you look over here, you see that the odontoid is in the center. This is for the Jefferson fracture, Jefferson, you see that the lateral masses are expanding, and therefore you see that the arches are broken, and therefore the canal is widened, and this overlap will tell you that there is a fracture. While odontoid fractures, I'm going back, you can see that there's a step or few millimeters over here, and what is important in this is to tell whether the transverse ligament is torn or not. The length is 6.9 millimeters. If it's more than this, then it will tell you that it's torn. At times, the transverse ligament is torn with a fragment of bone, and this can be treated conservatively. Otherwise, you need surgery. So these are the three types of fractures in the odontoid. In the patients that don't need surgery, you can treat them in a halo cast or vest. Now, if it's more than 5 mm displacement, you have to do surgery. You could put either a screw anteriorly into the adenoid. You can put 1 or 2 screws, or you can do it posteriorly by fusing the atlas to the axis. Okay, so enough of these. I would just like to mention briefly about from C4 to C6 level. If you can have a unilateral facet dislocation, this is a fracture where anterior flexion, you can have one facet which is displaced or 2 facets. If it's one facet, the displacement of the vertebral body would be around 25%. If it's 2 facets, it would be 50%. When one facet is dislocated, then if you take a lateral, you see that in the view, the place of the dislocation will appear as an oblique view, while the others will appear lateral. Now, in complete dislocations, where both facets are displaced, this, most of the times, there's transection of the cord. Let me tell you, at the lower level, the cord is fit tight within the canal. The height of the width of the canal is around 16 to 17 millimeters. You have to be very careful. And there is little space, and therefore you can have injuries. In these levels, where you have either unilateral or bilateral dislocation, you can have an associated disc rupture. You have to be careful, because as you're trying to reduce the dislocation, the disc can cause further pressure and paralysis. For this reason, an MRI will be indicated to rule this out. Or you can apply gradual traction in a very careful way, as White has described, and this, every now and then you do a neurologic workup for each few kilos that you add weight to reduce the dislocation. At times you have a perched dislocation, a locked dislocation. And in these cases, you will have to go ahead surgically to relieve it. Now, if you have no disc associated, the work is done totally from posterior. If you have an associated disc, then you should go anteriorly, remove the disc, do your fusion, and if necessary, go ahead and do a posterior fusion at the same time. You can have lower down also fractures of the vertebral body, which is known as a teardrop fracture, secondary to compression, that involves the entire vertebral body. So you have to know these points, okay? Let me see. This is scalp lateral, oblique views. Let me see. I just would like to stress this point. In the cervical spine, the way we can tell whether there is an acute injury is by looking at the soft tissue mass in front of the vertebral bodies. At C7, it measures 18 millimeters. At C6, 18. At C3, it's 7. At C2, it's 8.5, and C1, 8.5. If these are more, you have to worry about it. There is an associated injury, soft tissue injury. There's something else I would like to mention about Shiwara, spinal cord injury without any radiologic evidence. These are injuries that occur in children. And nowadays, in the past, we had simple x-rays. Nowadays, we have the MRI, and it helps us and tells us a lot about the site of the injury. In the past, we couldn't tell at times where the site of the injury. When you ask for a flexion extension view of the cervical spine, you should not ask it in the acute phase. You should wait for the soft tissue swelling to subside and then ask. The whole purpose is to rule out instability. Thoracic and lumbar fractures. Most thoracic and lumbar fractures result from vertical compression or compression flexion injuries. Vertical compression burst fractures are most common and typically occur in the thoracolumbar region. We've seen so many fractures of the spine, and the far majority were in the thoracolumbar region. In the upper thoracic, T1 to T10, the rib cage provides support and protection. Lower lumbar vertebrae, L3 to L5, are larger. They are larger, as I told you. The lower you go, the bigger the vertebra, and these are more resistant to injury. The thoracolumbar region, T11 to L2, is a transitional area between the less mobile thoracic spine and more flexible lumbar spine. So you have a mobile and you have a flexible. Therefore, you can have an injury secondary to this. This is a common site, especially in the cervical at the level of C7, T1, and at the thoracolumbar region. Treatment is decided after the extent of the injury and the presence of neurologic compromise have been discerned. When the thoracolumbar fracture involves only the anterior column, the anterior half of the vertebral body, the injury is stable and can be treated with a supportive orthosis and early ambulation. More extensive injuries also involve the middle column, the posterior half of the vertebral body, plus the annulus fibrosus, and the posterior longitudinal ligament, and the posterior column, all structures posterior to the posterior longitudinal ligament. The injury is stable and can be treated non-operatively when the fracture involves only the anterior and the middle column. No neurologic deficit is noted, and less than 20 degrees of kyphosis and less than 50% canal compromise are observed. Now, I'll tell you, when you have a loose fragment within the canal and it's less than 50% compromise, you can wait and be patient. Why? Because we know that there is a large amount of pulsation of the CSF. The pulsation itself will decrease the compression. In addition, there is remodeling at that level. And if you take an X-ray after 1 year, you see that the canal compromise is far less present. Surgical stabilization is usually indicated when a neurologic deficit occurs, when the injury involves all three columns, and when more than 20 degrees of kyphosis or greater than 50% canal compromise is noted. Minor spine injuries such as transverse process or spinous process fractures can be treated symptomatically. However, such fractures may be associated with more significant injury and require full evaluation. Fragility fractures of the vertebral body associated with osteopenia and osteoporosis can be very painful and can worsen any premorbid symptoms of the back pain associated with degenerative disc disease and sometimes can be intractable to non-operative management. What can we do? Nowadays, it's very popular among the orthopedic surgeons in Lebanon. Injection of polymethylcrylate in the vertebral body using fluoroscopic control. You can use a tampa and expand the vertebral body, but this does not expand very much the vertebral body. But by just putting your patient in the prone position will correct the deformity. You expand the tampa, and following this, you leave an empty space in the vertebral body. You deflate the tampa, and you remove it. Then you insert your cannula and you insert the cement. We like to insert our cement anteriorly. And we believe that cement in these fractures, they pass between the fracture fragments and they adhere them together. They adhere them together and the pain will go. There are some patients where the pain does not go immediately, but after 1 week to start saying that they're improving. But don't forget you're putting something solid in, something solid. By putting something solid, the adjacent vertebral bodies are under stress, and after 1 year or 2 years or 3 years, they can have a fracture. So keep this in mind. You have to pay attention to this. But also don't forget, there are complications from this. You can shoot emboli of cement, or you can shoot other forms of emboli, or the cement can pass into the canal. And beware, as you're doing it, if you have a fracture, that you get the fracture of the middle column and you're injecting cement and it goes into the canal, you can get paralysis. I know of many cases that have occurred, and there were medical legal problems. So you have to keep careful about this. Okay? So beware of complications of the procedure. They can have infection, nerve injury, load transfer to other involved vertebrae, and recurrent symptoms. Injuries to the spine in children. I would like to mention the odontoid is quite common for it to occur in children. They have Shawara, spoke about it. The spine is more elastic in children. MRI would help us in the diagnosis. You have to know about Hans fractures, flexion distraction injuries that occur in the thoracolumbar region. They can occur through bone or within the disc. If it's through bone, you can treat it conservatively, and if it's in the disc, then you have to operate. If you look, when you put these safety belts or seat belts, and the patient is in a car and there's a car accident, the axis of flexion is in front, and as a result, there's a flexion, distraction, injury. So don't forget about this. Don't forget with the Hans fractures, you have also a high incidence of splenic injuries, colon ruptures, and liver and other complications of injuries. Now, you have to think of also the WODs or the whiplash injuries. These can give you pain. There are deep muscles in the area, and they will end up having pain with flexion. And these are the whiplash secondary to cars entering the behind of other cars and causing the injury. They will have occipital headaches and activity intolerance. They need pain medications. Many are psychologically affected. If you look at this slide, you will see that the patient, how she's seated, and she, first of all, she has an extension followed by a flexion injury. They have multiple tears, and they go on for months, and they claim workman compensation, these patients. So I'm not going to go a lot on these cases. Now, I want to go through the pediatric conditions in around 10 minutes, and then I'll shift to tumors. I want to show you two films on how to excise a tumor in the spine. You see, congenital torticollis is quite common. We see a lot of these children where you see that the head is tilted to one side. And if you palpate the sternocleidomastoid, you see that there's a hard fibrotic area within the sternocleidomastoid. We think that this can be secondary to a compartment syndrome. They end up having a contraction. You know, the sternocleidomastoid extends between the mastoid and the medial end of the clavicle. It contracts and it puts the patient. Now, children who are not treated, who keep like this, they will end up having this symmetry of the face. So you have to pay attention to this. You have a good physiotherapist to work on the patients, that put all the attractions to the normal side, to the abnormal side, so that the child will be forced to turn around to look at it. This will help in the correction. So beware of these points. Okay, many feel that this happened during the child was in the third trimester and there was a compartment pressure, compartment syndrome. It is a localized compartment syndrome, but we're not 100% sure of it. This shows you the patient, shows you the dissymmetry that is present. So Pimple file syndrome is a condition where you have a low hairline, a short neck, you have a Sprengel's deformity. One scapula is lower than the other scapula. And they have a congenital fusion of multiple vertebral bodies. I'll show you. This is a Sprengel's deformity. The problem with these is that they have a fusion over a long area, and what happens, there's extra stress in whatever disc is remaining, and with time they begin to have signs and symptoms. This is showing the child further. So the child would have a short neck, they have a low posterior neckline, they have limited spine motion, and the degree of cervical spine disability depends on the extent and location of the fusion. If only one level is involved, the neck appears normal and the diagnosis is made. So look at this child. Okay, so I'm going to discuss this, and then I will very briefly discuss others, then go into tumors, because I care about this. You see, the atlantoaxial rotatory subluxation can occur secondary to trauma or an infection in the area. Glisted abscess can cause it. And what happens? It's a rotatory dislocation, anterior dislocation, in 3 stages. In the last stage, it's a posterior subluxation. All these are subluxed or dislocated. And the treatment is by traction. The most of the time, it's a problem of 1 week to 2 weeks, and then the child returns to normal. And you can put them in a collar. It's the time in which I've seen these patients was between 2 and 12 years. So you have to pay attention to this. And this is how the child will look. They call it the cock-robin torticollis. Okay? So they have also sternocleidomastoid spasm. And the way you can describe it is by doing dynamic CT views. And this shows you how it would appear. This symmetry. Okay, so I'm going to go. Scoliosis, you have the idiopathic and you have the congenital, which is due to failure of segmentation or a segmentation or a combination of the two. And treatment is difficult, especially if it's progressive. We have to put growing rods in them. Either we used to put them between the both vertebrae, distracting them, or put it between the use the ribs as a sort of a pointed area where we could distract them, or we can use these rods and repeatedly stretch them, or you can use it in a magnetic field, just as you'll use it in expanding prosthesis of the extremities for tumors, where you pass it through a magnetic field and it expands. And these patients, the problem with them, if you fuse them early, the alveoli are not mature, and as a result, you can end up having pulmonary hypertension and they die early. So, for this reason, we like to delay them as much as possible. Later on, after 7 years or 8 years, we fuse them. And we do a short fusion, not a long. Okay, so keep this in mind. Also, you can have failure of formation anteriorly, they will end up kyphotic. These patients, you should do a short distraction fusion or a fuse and very early, and they will correct with time. If you do a posterior fusion with a synostosis anteriorly, with time they can get some correction. Another point is when you're operating on these patients, you have to pay attention that you don't have a diastematomyelia, a division of the cord, or a central bar, or a tethered cord, because as you're correcting them, then you will have problems or paralysis. So this is as far as scoliosis is concerned. You have also the idiopathic form of scoliosis. In school, we use scoliometers to measure. If there's a 7-degree or more tilt, then we send the patient to a specialist. You have to know how to do the cup measurement. And you should examine the patient while bending forward because the rib hump will become more prominent. So we divide idiopathic scoliosis into 3 types. We have the infantile, where the curve is convex to the left, and these patients outgrow this scoliosis in the far majority. But we can tell whether it's going to progress by doing certain measurements on the spine and these deciding whether it's going to progress. Let's say at the apex of the curve, if the rib is dislocated and there is a difference between an angle on the normal side with the angle on the abnormal side of more than 20 degrees, it's going to increase. Please look this up. I don't want to go into detail because this is a lecture as a whole. And you have to look at congenital forms. So we spoke about the idiopathic as infantile. It's to the left, the convexity. Then you come to the adolescent, the juvenile form of the adolescent juvenile. It is a convexity to the right. And then you get the adolescent, the convexity also is to the right. We know it's more common in females, 7:1. In the early stages, when there is an angle of around 20 degrees, then we would say that it's equal in females and males. Don't forget that there are conditions where you can have scoliosis in patients with neuromuscular disease, cerebral palsy, myelomeningocele, muscular dystrophy. They develop scoliosis very early, and when they begin to develop it, they should be fused early. Spinal muscular atrophy and Friedreich's ataxia, vertebral conditions, benign bone tumors, we know it. We know, I'll tell you, look at osteoderma. It gives you a curve that occurs at the wrong time and place. And with time, you see that the tumor is localized to the concave side. And if you discover it early and you remove the osteoderma, then the curve will correct. Then you have to think of spinal cord conditions like syringomyelia, tethered cords, neurofibromatosis. I've seen severe cases of scoliosis, of neurofibromatosis type 1, Marfan syndrome, and Ehlers-Danlos syndrome. All these, but no pain occurs from the idiopathic form of scoliosis. You have to keep that as well. And you do a forward bending so as to look at this patient standing. You don't see the rib hump, but when they bend forward, you see the rib hump. Okay? So you have to pay attention to this. Okay, this shows you how you measure the Cobb method. You have to know about the central sacral line, which will help you choosing the distal end of the fusion. We don't like to operate on these patients unless the curve has reached beyond 40 degrees. You have to know how to measure the curve. It's usually convex to the right. Of how low we judge where the central sacral line passes. Yani, for instance, if you look at the middle uh, slide, which is over here, the middle slide, I would fuse down to this level. Over here, you see that it intersects here. So I will fuse down to this level. So you have to pay attention. We brace these children when they have a curve between 20 and 40 degrees. So you have to realize we have various types of braces. We have the Boston brace, we have the Milwaukee brace, we have so many braces. And you can look them up, read about them. So, and the surgeon, in the past, it was very difficult to treat these curves. We used to operate them, put them in casts, keep them in bed for a long time, etc. Nowadays, with the segmental fusions, using pedicle screws with corrections, we don't need to do all this stuff. Anyway, this is a field in itself. When to operate, you look at the Reiser sign. Reiser sign, you see ossification, parosteal ossification of the apophysis of the ilium. If it's ossified 25%, means that the curve is going to progress. If it's 50 or 75 or 100, it's going to progress. Once it's reached 100, then you can operate. Not that important. You should look at the menses of the girl. If she has hair in the pubic region, if her breasts are developed, if she's having all these findings will tell you that the curve is not going to progress, and then you can do your correction. Why? Because if you fuse these patients early, you'll end up having a crankshaft deformity where you'll have a curve arriving adjacent to your fusion. So you have to be very careful in your patient. As far as kyphosis, you can have postural kyphosis, you can have Scheuermann's disease. Scheuermann's can occur in two regions, one in the thoracic spine and the other at the thoracolumbar region. These can be painful. It occurs more common in boys where you have a positive sagittal imbalance, positive sagittal imbalance. And these curves, you know that in the thoracic spine, the curve is between 20 and 40 degrees. If it becomes more than 20, if it becomes 50 or 60, then you may have to operate on these patients to correct the deformities. These are positive sagittal balance. So I think this is enough for Scheuermann's. I want to come to isthmic spondylolisthesis. Is a defect in the pars interarticularis in children. Usually it doesn't become more than type 2, where according to the percentage of displacement of the vertebral body on the one below, it's common between L4-5 and L5-S1. And you can have a spondyloptosis where the whole vertebral body slips forward. Okay, so you have to pay attention to this. These are the types. 1, 20, less than 25, 2, 25 to 50, 350 to 75, all these on the slip. On the other hand, you can have a long posterior arch, a dysplastic, or on the other hand, you can have traumatic or iatrogenic. But this occurs, the isthmus occurs in children at 5 years. We haven't seen it in younger children. We don't know why. We've seen it at the age of 5, and it usually occurs secondary to sports like ballet or trapeze sports, where you have a lot of hyperextension. The superior facet impinges on the pars interarticularis, and it can cause a defect. You have to follow up these patients. If they don't pass beyond type 2, then you can treat them conservatively. Otherwise, if it passes, then you have to do a posterolateral fusion in these patients. Okay, so keep this amount. So the most common is L5 vertebra. The incidence is in athletes who have repeated loading of the spine, like gymnasts, football players, etc. So, and they have a lot of tension on the pars interarticularis. So it's more common in males and certain ethnic groups like Eskimos. And this is very important. So they have back pain. Another thing is hamstring tightness. This is very important. You ask the patient to try and touch the floor. You see that the hamstrings are tight. You see that there is nearly a flexion contraction of the knee from patients who have significant spondylolisthesis. A view that should be taken is an oblique view. You have to know about the Scotty dog appearance of each, what structure gives you what. You can see over here, it looks like a Scotty dog, the legs, the nose, and the neck, like a Scotty dog. Look at it. This is a pars interarticularis fracture, and you can see this is it when it's separated. So you have to know what the Scotty dog is and what each one ends. Now, if they do have pain, you have to do a fusion. Spinal infections, I have to do this before we come to the tumors. Infections of the spine encompass a variety of conditions ranging from osteomyelitis of the vertebral body, discitis, and granulomatous lesions to abscess formation within the spinal canal. These conditions can exist in isolation or frequently in combination with each other. Vertebral osteomyelitis is an infection of the vertebral body, intervertebral disc, and or associated structures. Some authors believe that vertebral osteomyelitis and discitis represent points on the spectrum of the same disease. Vertebral osteomyelitis is also termed spinal osteomyelitis, spondylodiscitis, septic discitis, and disc space infection. Two types of vertebral osteomyelitis are pyogenic osteomyelitis, which is more common in developed countries, non-pyogenic vertebral osteomyelitis, which is more common in developing countries. One in developed and the other in developing countries. Vertebral osteomyelitis can be classified as acute, occurring within several days to weeks, or chronic, occurring over several weeks to months. Common etiologic bacteria in pyogenic osteomyelitis include Staph, E. coli, and Propionibacterium acne. Non-pyogenic vertebral osteomyelitis include granulomatous vertebral osteomyelitis and is commonly caused by Mycobacterium species Nocardia brucella and Actinomyces and fungi. So, how are spinal infections classified? Host immune response, pyogenic versus granulomatous. Anatomic location, vertebral body, disc, epidural subdural facet joint, paraspinous soft tissue. Infectious route, hematogenous, local extension, direct inoculation, and host age, pediatric versus adult. The most common method for bacteria to spread to the spine is by the hematogenous route and include infected catheters, urinary tract infections, dental caries, intravenous drug use, and skin infection. The second is from an adjacent soft tissue infection or paravertebral abscess. The third route is direct inoculation via trauma, puncture, or following spine surgery. The nucleus pulposus is relatively avascular, providing little or no immune response and thus rapidly destroyed by bacterial enzymes. The disc is nearly always involved in pyogenic vertebral infections. In contrast, granulomatous infections typically do not involve this disc space. Pyogenic vertebral osteomyelitis is most common among adolescents, elderly patients, intravenous drug abusers, patients with diabetes or renal failure, and patients who have undergone spinal surgery. Patients with immune compromise, rheumatoid arthritis, and patients on chronic steroid therapy are also at increased risk. So, the most consistent symptom, of course, we know it's back, neck pain, which occurs in 90% of the cases. But the pain is unrelated to activity. They usually have fever in approximately 50% of cases, neurologic deficits, 17%, and radicular pain, 10%. Weight loss is common. Spinal deformity does occur. It's quite common. A delay in diagnosis with 50% of patients reporting symptoms for more than 3 months before diagnosis. The lumbar region is the most common site of pyogenic vertebral osteomyelitis, followed by the thoracic and least in the cervical. Staph aureus is the most common. Staph epididymis, Pseudomonas can occur. It's quite common to occur in drug intake in patients on morphine, steroid, and that's it. These are gram-negative. E. coli, Pseudomonas, Proteus are associated with spinal infections and genitourinary infections or procedures. Drug abuses, Pseudomonas, anaerobic infections are common in diabetes and following penetrating. Now, when you take a culture, you have to keep it for 2 weeks. And if you are suspecting tuberculosis, you should centrifuge the specimen and then do your culture. The culture should be kept for a few days. You can do a PCR on these patients. These patients also have an elevated sedimentation rate and a CRP, and these are points to keep in mind. Imaging studies all help, whether magnetic resonance, technetium, scans, a biopsy should be taken. You can do a percutaneous biopsy using a core, or if you're not successful, you'll have to do an open biopsy. So you have to think also a leukocyte count more than 10,000 is important. Blood cultures in 1/2 of the cases can be localized. Radiographs Findings are not evident at least for 4 weeks. The earliest detectable radiographic finding is disc space narrowing, followed by localized osteopenia and destruction of the vertebral end plates. Radiographs remain valuable to rule out other non infectious etiologies responsible for back pain symptoms. MRI is the imaging modality of choice for diagnosis of vertebral infection. It provides detailed assessment of the vertebral body, disc space, spinal canal, and surrounding soft tissue not provided with any other single test. The typical MRI findings are associated with pyogenic vertebral infections, and there is a decreased signal in the vertebral body and adjacent disc on T1 weighted images, and an increased signal of T2. The typical findings associated with pyogenic vertebral infections are decreased signal in T1 sequences and increased signal in T2. Look at over here. Look at over here. T1, you have on the left-hand side decreased signal, and T2 increased signal on the right-hand side. Vertebral abscess present also demonstrates increased uptake of T2 weighted images. Gadolinium will help further. Radionuclide studies are also helpful, and computed tomography tells us a lot. A biopsy of the site of the presumed vertebral osteomyelitis or discitis is essential to provide a definitive diagnosis, identify the causative organism, and guide treatment. And before the biopsy should be done before the initiation of antibiotics. They should be discontinued for 3 days before the biopsy. Computed tomography guided with crate needle biopsy are done, and it could identify the organism in 70% of the case. Closed biopsy is negative after 2 attempts, and an open biopsy should be done. When you should stain for gram stains, you do acid-fast stains, aerobic and anaerobic cultures should be done, fungal and tuberculosis cultures, bacterial cultures should be observed for at least 10 days to detect low virulent orders. Tuberculosis cultures may take weeks to grow. Histology studies should also be performed to detect neoplastic processes and to differentiate acute versus chronic infection. The goals of treating vertebral osteomyelitis include early definitive diagnosis, eradication of infection, relief of axial pain, prevention or reversal of deformity, okay, and correction of spinal deformity. Non-operative treatment includes antibiotic administration, treatment of underlying disease processes, nutritional support, and spinal immobilization within orthosis. Antibiotic selection is based on identification and sensitivity testing. Consultation with an infectious disease specialist is recommended. Intravenous antibiotics should be kept from 4 to 6 weeks, and the way to discontinue and transfer it to oral is dependent on the reduction of the erythrocyte sedimentation rate and C-reactive protein. You can have a relapse of the infection in 25% of the cases. You can have mortality in 2 to 17%. Non-operative treatment is reported as successful in up to 75%. So You can think of this. The most consistent predictors, patients younger than 60, patients who are immune competent, and decrease. When do we resort to surgery? Hope it unsafe. Failure of appropriate non-surgical management as DOCSR or C-reactive protein, or refractory severe back pain. Drainage of a clinically significant abscess associated with sepsis, spinal cord, cauda equina, or nerve root compression. To treat progressive spinal instability secondary to extensive vertebral body destruction, correction of progressive or unsuccessful spinal deformity. Surgery should achieve complete debridement of non-viable and infected tissue, decompression of neural elements, long-term stability through fusion, use of autogenous graft material is the gold standard. The surgical approach generally should include anterior debridement and grafting, followed by a staged or simultaneous posterior spinal stabilization procedure. This is a patient who was 60 years of age, and the magnetic resonance showed an infection. And you can see she also, this man had a discitis, and the patient was operated both posteriorly and anteriorly. A bone graft was put and anteriorly and grafted together with posterior instrumentation. So, another point is to think of epidural abscesses as a panel for the spine. You have to, if you have an epidural abscess, which is a collection of pus behind the vertebral body or in front of the lamina or compressing the cord, you have to decide which approach to use. Now, you have to use an approach that also will not give you worsening of the instability and neurologic deterioration. So you have to think of several things. We have mentioned these. Now I'm coming to epidural abscess. This can result from a hematogenous spread, local extension, or direct inoculation. The risk factors include intravenous drug abuse, diabetes mellitus, prior spine trauma, renal failure, and pregnancy. And the majority of cases are located in the thoracic spine. The initial presentation includes localized pain and fever with elevation of the ESR and C-reactive protein and leukocyte count. Blood cultures are positive in 60% of the patients. Without treatment, significant neurologic deficits occur and eventual paralysis may develop. Significant neurologic recovery is observed in patients with mild neurologic deficit or paralysis of less than 36 hours duration who undergo surgical intervention. Complete paralysis of greater than 36 to 48 hours duration has not shown recovery. This is an emergency. You should evacuate the pus as soon as possible. The death rate associated with an epidural abscess has been reported to be 12%. Thank God we finished the spine as far as biomechanics, as far as degenerative, as far as disc. Now we come to bone tumors of the spine. And this is what I'm after. Why? Because I want to show you two procedures. Bone tumors of the spine. Primary tumors of the spine encompass a wide spectrum of disease processes, requiring many different treatment algorithms. Primary bone tumors account for 2 to 5% of all spinal tumors, while metastatic accounts for the far majority. Benign tumors, of course, are more common than the malignant. Pain, first intermittent, then continuous, mainly at night, and quite often may mimic a metastatic tumor. The treatment of spinal tumors has evolved over the course of the past decade with the advent of improved diagnosis, staging, non-surgical and surgical treatment. Patients younger than 20 years, 72% of the tumors were benign. So the younger the patient, the more chances are that the tumor is benign. Of course, in a study, we used 20 years as a limit. Anything less than 20 was more likely to be benign. While it's more than 20, it's more likely to be malignant. Benign lesions occur more frequently in the posterior elements, such as osteoblastoma, osteodystroma, aneurysmal bone cysts, osteochondromas, whereas malignant lesions usually occur in the vertebral body. These are the benign and the malignant tumors that occur in the spine. Some are very rare and some are frequent, like osteodystroma, like eosinophilic granuloma. I've seen several cases of aneurysmal bone cysts. Hemangiomas are known to occur in 11% of bone tumors. It occurs in the spine, especially in the thoracic region. I've had, in my experience, 2 cases of osteosarcoma, 1 case of chondrosarcoma, 4 cases of Ewing sarcoma, 2 cases of chordoma, solitary and multiple myeloma, very frequent, large number. I've seen leukemia in around 5 cases and lymphoma in around 6 cases. Osteodystroma. It is the most common. It's less than 1.5 centimeters in diameter. The peak incidence is at the age of 15 years, and up to 25% occur in the spine. 70% of painful juvenile scoliotic deformities occur secondary to osteodystroma. They occur at the wrong time and the wrong place. And usually the nidus of an osteodystroma usually occurs on the concave aspect of the curve. In addition, if you do remove this osteodystroma early, the curve will correct. If you remove it late, it will not. Pain is worse at night and relieved by non-steroidal anti-inflammatory drugs. Bone scan is most sensitive. A CT scan is most specific. It usually involves the posterior structures, the lamina, the transverse process. In the past, We used to operate them. We used to remove them. We used to correct them. We used to do a bear down technique. Excision of the lesions resulted in reliable pain relief, and most associated scoliotic deformities improve. Good short-term results with percutaneous radiofrequency ablation and burn-down technique, namely CT-controlled osteoid osteoma, have been very popular. But the problem with these, of course, they relieve you of the pain, but you're not sure when you're operating them and excising them, and by ablation or by burn-down technique. Most probably you won't be able to identify the pathology on these tumors. Your identification is by radiology, by scanography, and that's it. Osteoblastomas are larger than osteomas. The pathology is the same. You have osteoblasts, you have a lot of osteoid tissue, and this is also a benign tumor, but it can be aggressive. In this patient had an osteoblastoma that was extending into the lamina, down the pedicles, down to the vertebral bodies. There have been cases that metastasized from an osteoblastoma. It can be relieved by non-steroidal anti-inflammatory drugs, but not as common as occurs with an osteoid osteoma. Pain is more activity related. Cortical expansion can result in impingement on neural elements. Painful scoliotic deformities do occur. Histologically, they are often indistinguishable from osteostomas. The spine is involved in 40%, while in osteostoma, the spine is involved in 25%. The posterior arch is involved in 55%. These are expansile lesions. You should distinguish it from an aneurysmal bone cyst. Surgical resection is the treatment of choice. Local recurrence occurs in 10% to 15%, and as high as 50% in patients with high-grade subtypes of osteoblastoma. Malignant transformation has been documented. Giant cell tumors, pain, and radiculopathy are the most common presenting symptoms. There's often a significant delay between the onset of symptoms in the spine and the diagnosis. They are usually diagnosed during the third and fourth decades of life, more frequent in women. The sacrum, I've seen quite a few. I've seen 3 cases, and in children, I've seen 1 that we confused it with a tuberculosis. The difference between a giant cell tumor when it occurs in the sacrum and the chordoma is that the giant cell tumor occurs at the periphery. The chordoma is usually in the center of the sacrum. Okay? They consist of giant cells mainly and mononuclear cells. You see the nuclei of the mononuclear cells are exactly the same like that of the giant cells. And you look at the wall of the giant cell. In the past, there was a classification that was depending on the wall, whether it's irregular or not. If it's regular, it looks more of a benign nature, and the irregular, it was of a malignant. Actually, there's no clear-cut classification of giant cell tumors. It consists mainly of osteoclast giant cells. There is zones of necrosis, hemorrhage, hemosiderin, deposition, and reactive bone formation. Relatively few mitotic figures in relation to dense cellularity of the tumor. It's treated by curettage, cementing, and bone graft. En bloc surgical resection is preferable if possible, as it reduces the recurrence rate. A large 2012 series of vertebral giant cell tumors managed with en bloc spondylectomy reported effective treatment of anything stage 2 tumors with intralesional curettage. If it's stage 3 tumors, they had high rates of local recurrence when curettage was performed, and it was concluded that en bloc resection should be considered. This is the anything. If you look from type 1, 2, and 3, you see in type 3, you should do an en bloc. In type 2, you can do a curettage. In the other stages, it's quite difficult prognosis. But nowadays, what we're using, denosumab, Prolia, we're using it, and it is shrinking the tumor by interfering with the rankle. And for how long, we don't know how long we should use it. And we've had the recurrence of the tumor following it. So you have to pay attention to this. Now, in the spine, for a giant cell tumor, you have a poorer prognosis. The recurrence rate reached 80% in grade 3 giant cell tumors. Metastasis occurs in just under 10% of patients. The use of monoclonal antibody targeting rankle, such as with denosumab, has proved effective in treating giant cell tumors. Although the antibody affects the giant cells, these cells are not the actual oncologic cells in giant cell tumors. The stromal cells remain after treatment with rankle inhibitor, and this explains why recurrence is high. Therefore, after use of rankle inhibitor is discontinued, the tumor returns. One of the most important effects of rankle inhibition is the effect on soft tissue extension. The soft tissue mass often decreases, and in some instances, the tumor retreats to the bone of origin, which effectively changes in anything stage 3 tumor to stage 2, and possibly you can do an en bloc or remove it. Denosumab alone is effective in relieving pain, increasing the ossification, sometimes reducing the tumor volume. It can be considered an excellent solution in spine giant cell tumors whose surgical treatment cannot be anything appropriate or is associated with unacceptable morbidity or loss of functions. It is still impossible to state when the safely stop the treatment. We don't know when to stop. Chondroblastomas are rare. It has been reported in a few cases. It occurs in the posterior elements. And if you take a pathology, you see that it's like a chicken wire appearance. The pedicle is usually involved, and the treatment is curette-mount. Osteochondromas occur on the transverse processes. They are rare, usually in the posterior elements, and it's treated by excision only if there's pressure on the nerve. At 10% involved the spine, they arise from the posterior elements. They are slow growing. Eosinophilic granuloma. I've had so many patients. I've had over 30 patients of eosinophilic granuloma. It is known by the tempo phenomena. There's flattening of the vertebral body in one place, then it regrows, and the flattening occurs in a different place. This is called the tempo phenomena, and the flattening is called the silver dollar sign. Silver dollar sign. It is characterized by a production of eosinophils, which are quite common and located in the lesion. And you find that there are some Berbeck's granules within the macrophages. Treatment Focal areas of well demarcation, bone resorption, vertebral plana 15%, males are 2 to 1. Many resolve on their own. Surgical intervention is indicated with progressive kyphosis or neurologic symptoms. Now, I've received this case. This was a woman, 36 years old. She complained of pain in the thoracolumbar spine. She was being followed by a gynecologist, and throughout, he couldn't explain why this patient is having pain. On examination, she had no neurologic deficit, but she had tenderness at the thoracolumbar region in the posterior arch region and around the spinous process. So what did I do? I asked for a technetium scan. At the level of L1, you see that there is an increased uptake. And then I asked for an MRI, which showed a defect, showed you, which was apparent on CT scans. And what did I do next? You see that it's a tumor which is of benign nature. There's sclerosis around the lesion. The defense of the individual is sufficient. I did a core biopsy, turned out to be eosinophilic granuloma, and I injected steroids, and she was cured. I took x-rays later, did not show the lesion anymore. Aneurysmal bone cysts, I've had around 5 cases, and the aneurysmal bone cyst involves the posterior arch, it involves more than one vertebra. And the problem with this is at times malignant lesions you have associated in aneurysmal bone cyst. And this shows you it over here. The spine is involved in 10 to 30% thoracolumbar spine, and it's bubbly in nature. So on MRI, you see fluid levels. You should be very precautious of it being malignant. And the treatment is curettage, wide local excision, embolization, and radiation. Local recurrence is 15 to 30%. Mangiomas occur in 11% of individuals. It gives you a honeycombed appearance on CT, and it's quite common, and we don't treat these patients. You see that the vertical trabeculae of the vertebral body is intact, the transfers are gone. We don't treat them unless we get symptoms such as expansion, cortical compression, etc. So this is radiosensitive, but embolization does help in these cases, and at times we do a vertebroplasty or kyphoplasty. Now let's come to the interesting part, osteosarcoma. Now I'm going to show you a case of mine. This is a patient who came presenting to me with pain in the thoracolumbar region. She was also being treated by a physician and could not explain the reason. I asked for all these studies, and I turned out to have this lesion. You can see the difference between the eosinophilic granuloma and this. You see the boundaries are not that good. You see it's not clear, okay? So look at this lesion. This is the lesion over here. The boundaries not defined. It's extending into the vertebral body. The patient had a core biopsy. They reported an aneurysmal bone cyst. I was not convinced. This is the scanogram. So what was operated? It was operated in 2 stages. And I will tell you that to operate, our group of surgeons operate at our institution. They operated her in 2 stages, being that it was an aneurysmal bone cyst. But after the first stage, another biopsy proved it to be osteosarcoma. And you can see this patient ended up having fixations through all anterior and posterior. But I'll tell you, I was not happy. I would have liked to do it, as I'm going to show by Mendel's technique, where he will be describing of how to excise it and what to do. Now, this is the patient. This is Mendel speaking. That's when you resect the vertebral body. You have to think that you're going to end up like this, and this can lead to paralysis. Now, what I want to mention is if you look over here, prior to any resection of a vertebral body, you should insert pedicle screws into 2 or 3 vertebrae proximally and distally, and insert a bar in. Why? Because when you resect the vertebral body, it becomes totally unstable, and you can end up with a loose area which could damage your cord. Over here, you have the side, you have the ribs. I'm going to go up again. Continue, Dr.
دكتور جون there is no sound ما فيش صوت في المحاضرة. دكتور جون سامعني؟ there is no sound.
Okay. So chondrosarcomas do occur, and Ewing sarcoma do occur in the spine. And I'm going to terminate this lecture with chordoma. This is a chordoma. If you're interested, I will show how this tumor is excised. I want to show you this. If you're interested, one of these days is we can show you these tumors. على كل حال, I would like to end this lecture and to thank the group for their patience for listening to this lecture. Thank you. Thank you very much. Are there any questions? شو يا خالد؟
دكتور جون
ايه
كيفك؟
انا عطشت اللكشة بالاخير لان بعتقد الاودينس تعب. شو رايك؟
كلهم يعني موجودين على الزوم يا دكتور احنا؟
بدكم تقشعوا البروسيجر تبع الكوردوما؟ شو بدكم؟
ايش قلت يا دكتور جون؟
ايه
شكرا جزيلا المحاضرة يعني لمت كل شيء بالسباين. تسلم.
طيب ثانك يو
شكرا لك يا دكتور جون.
يلا. لا انا بتشكر الجروب كله.
الله يحفظك. الحضور اليوم كويس كثير.
وانا بتشكر اليمنيه لان لو ما منهم ما كان صار هاللكشر.
الله يحفظك يا دكتور جون.
اكثر من هيك ما بقدر احكي. Thank you very much.
الله يعطيك العافية.
Thank you.
Thank you very much.